Like, wait for that. Hello, hello, check 1, 2, 3. Hello. இதான் கேபிள் HDMI கேபிள் அது கொஞ்சம் டிஸ்டர்பா இருக்கும் கொஞ்சம் லைட்டா ப்ரெஸ் பண்ணி என்ன பண்ணலாம் கீழே அது ஒரு பண்ண மட்டும் HDMI கேபிள் பண்ணிட்டு அந்த கீழே கொஞ்சம் வெயிட் பண்ணிட்டா வந்து few seconds.
சார்ஜ் பண்றது
சார்ஜ்
லேப்டாப் கால் பண்ணுங்க. I'll take care of that. But then the it's there. Yes. கவிதா ஏன் வீடியோ ஆஃப் பண்ணி வச்சிருக்கீங்க? ஏன் வீடியோ ஏன் இது மொபைல்ல ஓகே ஓகே பட் இதுதான் இங்க வரும் இந்த இடத்துக்கு இந்த லேப்டாப்ல வரணும் பேசுற ஒரு லேப்டாப்ல தான் லைவ் எல்லாம் பண்றேன்
எல்லாமே
அங்கே ஃபோக்கஸ்லாம் பண்ண சொல்லுவாங்க.
இதே கேமரா
சரி ஓகே அந்த ப்ரீசெட் வச்சிட்டியா?
எல்லாம்
சொல்லுங்க
Yeah.
Is it? Good afternoon, one and all. Those who are, good afternoon. Those who are attending physically here, they will get the accredited course certificate. And those who are participating online, they will get online participation certificate only, not the course certificate. Okay, so I request you to raise for the prayer. Please stand up. Need to welcome formally our course coordinators. Of Mr. Venugopal or any companies, please come. Course coordinator. Okay, so with this, we will Venugopal, Priyadarshi. Sir, you please come and join.
During fire.
Join.
हाँ दीदी 0 दे दे ये भी आपने कितना लगाया मैंने कुछ नहीं किया मुझे आपने 0 लगाया
It's
मैंने प्रिंट करना है 13 आया ये तो फ्लड होगा आज सैंड फ्रेश ब्लड एंड कल्चर चेंज और आईवी लाइन एंड पॉलिश कैथेटर
and officially we have inaugurated the program. Now I have been told to give the welcome address.
वैसे हम लोग भेजते नहीं पेपर हमें भेजना ही नहीं पेपर हम सिर्फ स्पेशल मीटिंग में साइड पे बाल करके ये मैं इसलिए निकाला क्योंकि मैं यूरो तक का भी नहीं यूरो वाले आएंगे
So before yeah, we'll call you. So we would like to switch off the AC.
जीरो प्रिंट चाहिए
And I really appreciate that you showed this interest. So before we actually start the course, what you know about tissue viability?
पूरा
So
ऐसे
what do you think tissue viability? Sister, do you think know anything about tissue viability? What do you? Let me check the. We will check it out. Okay. Ability of the tissue to survive. Very good. Very good.
Hello.
Anyone else who would like to say tissue viability? So when it comes to the tissue viability, we should remember the 4 C's. What are the 4 C's? 4 C's of tissue viability. First of all, what is tissue viability? Any tissue which is viable. And the viability means it should have a biological dynamic activity. If doesn't have that biological dynamic activity, that means the tissue is not viable. And that is the beginning of any wound management. You cannot start your wound management, be it a bed sore or venous ulcer, diabetic or traumatic ulcer, acute or chronic wound, as a nurse or as a resident, unless you know the viability question. So it means before you do anything, you must know what is tissue viability. Means the tissue has a dynamic biological activity or not. Now, how to test this? How to test this whether the tissue is viable or not? So for that you should remember 4C. What are the 4C? Anybody guess? Circulation. Very good. How to check the circulation? How to check the circulation? Clinical. You are not going to send the patient for capillary bleeding. If you prick it with the needle and if it bleeds, it means circulation is intact. And anything which bleed means it is a viable. Don't damage it, don't cut it, don't throw it. Correct? Second C. Anybody else? Color. By look, you can say if it is red color, there is definitely it's viable. If it is a brownish, blackish, doubtful, yellowish, there is a possibility it is viable or not viable. And when you prick it, it bleeds. It means it is definitely viable. So first C is capillary bleeding. First is circulation. Second is color. Third, consistency. Very good. Consistency. Take a photo. Consistency. If it is waxy consistency means already damage, biological, like when you bought. So by feeling, by touching, C means consistency. Contractability. Beautiful. Clap. So contractibility, how you will check contractibility? Less it contract, less the viability. So now you understand how no problem. And those people who are only, please give the seat to the participant. I want to make sure that they utilize it. Those who are not registered, they may stand up, whether it is a company staff or whether it is a only those people who have registered and dedicating this 5 hours should be here. Other people are only passively learning. Here. Okay. So what I told is then only you think of viability.org in Ireland. Tissue viability. You can become member. Tissueviability.org, and there is a journal, PubMed journal with impact factor of course is only a you should continue with those Journal of Tissue Viability. Ground, should we go ahead? Nurse or a resident or even a consultant, you have no idea, and what are you doing actually? You are playing with the not wound, with to very minute level.
இல்ல ஒண்ணும் புரியலையே இது என்ன பண்றாங்கன்ட்டு 15 பேர் மகேந்திரன் இருக்கிறாங்களா இது பேசுறோம் கேக்குதா
In the Europe as well as in the top degree in skin integrity. So imagine on new, he has conducted this
ஏரியில 2 பேர் வந்து ட்ரெஸ்ஸிங் பண்ணிக்கிறாங்க
tissue viability.
பார்க்கலாமா
Looking after the academics part of the kind of technology which will
விட்டு விட்டு கேக்குது இப்போ.
so is he coming online or activity should not be a trouble. So we will
கையில எழுதி விட்டேன் செல் நம்பர் கொடுத்துருக்காங்க கையை முழுவதும் யார் கொடுத்தாங்க நான் சூப்பர் சூப்பர்
our sitting.
எத்தனாம் தேதி
17
Pratik, please.
Thank you, sir. This mic should be okay.
Yes.
I think even without mic, it should be okay.
Yes.
The attendees are large in number, but the room is still so nice. Yeah, okay, no problem. So first of all, thank you, Dr. Chitoria and the JIPMER team for your warm welcome to all the Urgo Medical team today. We are really excited for how today goes and what we will be able to bring to you, but also what we will learn from you. I think that is also equally important. So I hope this will be a very nice session of shared learning between the Urgo Medical Education team and between the JIPMER team that is present here today for this program. I think before we can upload the presentation, I really want to point out that the fact that we had to do so much chair logistic itself shows the interest that everyone is having for the program. I was little afraid. Sometimes we go to many institutions, trust me, and sometimes there are a few empty chairs. But in JIPMER, that will never happen, I think.
Actually, we stopped because of the space constraint. So we thought those who are interested, why not let them learn online at least? So that itself shows the interest is not stopped at this level. It is there for many people who are joining this line and who are joining this course. But the problem is the certificates are given only for those who are physically coming. That is the constraint. But knowledge doesn't see the boundaries. You can always learn. Okay, so continue, Mr. Pratik.
No, thanks. So that's really great. So it's nice to see so many people joining in, and at the end of the day, we will be having a sharing of feedback, and we would like to know what you guys do.
this peak will show the couple of
Very good.
slides. It's not couple, but I will make it seem like a couple. No problem. And after you have a medium virus and tissue viability. I would like you to all to introduce yourself. Introduce yourself by name or designation. I start with Dr. Jacob. Like this. CHG is already done his MBBS, General Surgery, MS. He's doing MCS third year. So they will become the expert of the tomorrow's consultant.
Yes.
You are going to marry your husband. Don't think my husband is his friend. You tell your name, your designation, and then you will be.
My name is Onam Babu and
So they are all postgraduate already. They are already BSc, now MSc. So they are really a higher level. But this concept is new to them, so that shows the interest.
good afternoon, everyone. My name is Meka. I'm pursuing my second year at this university, medical surgical department.
Welcome.
I'm Sakti Lakshmi, SNO, Assisting and Care Unit, EMSD.
Also tissue viability. Today we are meeting like a friends and family. So no hesitation. It's a 6 hours of our train journey. We will talk to each other. We will understand each other. There is no formality. We are all like-minded. We are all medicals and paramedics, isn't it? So there is no question of any hesitation. You can always ask any doubt anytime.
Good afternoon. I am Mr. Satyajit Tangaraj, Deputy Nursing Superintendent from Bawnsai.
Very good. So we want some administrator also to implement this kind of courses and the very good.
Damani, Senior Nursing Officer, Bawnsai.
Very good.
Nursing officer from Bawnsai.
Very good.
I'm Prem Kumar, nursing officer from Bawnsai.
Very good. Anybody who is there outside can come here and sit and introduce. Yeah, please come. Please come. Any chair, we can have another chair. There is no doubt about it. You can bring more chairs. There is enough space. We can push this side. Only the participant I want here. Others can see on the mobile and how many more participants outside? 2 or 3. So bring the chair. But anyhow, physically you send them to introduce so that we should not delay. Send them physically here. Send them physically inside. Send them physically inside those who are participants. here can be brought later on. Let the introduction be over now, as Pratik wants, he wants to know who are the people. Call fast. No, send the participant inside. Where is the participant? Oh, only empty chair is there. Okay, okay. So, yes,
I'm Ratna Choki, nursing officer from Branch.
very good.
I'm Dr.
So he's the burns, he's posted in the burns only, exclusively.
I'm from public,
They deal with the all diabetes. Control the sound properly. It's over. Okay,
Yes.
give the mic back to us.
Okay,
Over to you, Pratik.
Thank you, thank
Now you know the crowd.
yes,
Of
absolutely.
course, your people, our people, there is no formal introduction.
Absolutely. Thank you, sir. Thank you, everyone. So there's clearly a very good interest from different backgrounds. We have general, okay, better? Thanks very much, sir. We have general surgery teams, we have burns ICU, a lot of people from MSc nursing, ortho, plastic. So it's a great mix, and that's probably what's required. I think coming together to solve the challenge of wound care is what we need for sure today. And I think we will be looking at things such as multidisciplinary approach, and that involves a lot of things during the course of this program. So why we are doing this? I think you have a lot of missions at JIPMER about being the best in class research, bringing best in class publications. Sir talked a bit about that as well when you introduced. So we have a mission at Urgo Medical as well. We want to heal patients suffering from wounds worldwide. As Urgo Medical, we operate in more than 30 countries directly, and we bring our solutions directly in these countries, as well as we do exports in some other countries. But our second mission, and very important, especially for today, is to make a difference for the healthcare professionals, for you, doctors, nurses, surgeons, in being able to help patients. Because at the end of the day, we are a company that manufactures the products, but we cannot directly reach the patients. That will happen only through you. And which is why it is very important for us to be able to hand in hand work on education front.
Yes, so Pratik said very clearly, they are the media between the patient and the doctor. They bring the technology, they do the all pilot projects, and then they bring the technology. Yeah, media time at our end to all the information. So thank you, Pratik.
Thank you, sir. And all our beliefs that we have, such as putting patients at the heart, caring for caregivers, or leading with science and clinical research, all this can happen only with you and through you. As sir said, we cannot reach the patient directly. You are the people who take care of the patients. The patient is in your competent hands. We can only do the job of bringing the product and also now bringing the education. And that's what we are trying to do here, because we really believe in this. We really believe in supporting healthcare professionals to help you make patients' lives better. And while we can do that quite easily first through bringing this huge portfolio of products, we have lots of products that are out on display later. You will be seeing in the lunch break. We have products for Urgo Clean AG.
So what he's telling you is, these are the various technologies which will help in the tissue viability, to maintain the tissue viability or to improve the tissue viability. Come, here chair is there. So here also chair is there. Please. Introduce yourself. Your name, designation, where are you working?
Working in burns ICU.
Thank you.
Designation?
Nursing officer.
Nursing officer. Welcome.
So yes,
Give
indeed.
the welcome drink to our participant.
So indeed, we do that first by bringing this portfolio, and I hope you will learn more about that portfolio, how to use it on your patients as well. But we do that with more than just bringing you products, and that is why I always say the industry hospital partnership is very important today in our country to further develop the education and awareness about wound care. Wound care is still a very nascent field. I have attended many CMEs where sir has also been a speaker. There is a lot of developments we see each time, and many times we see the speakers emphasizing the importance of improving education and awareness. And we want to do various initiatives together with you on that over the next, not only for today or not only for next month, but we want to continuously do it over a period of years. We can do it, of course, through clinical research. We would love to be associated with JIPMER and establish evidence. I'm just pointing out here on the slide some evidence we have established in India with Indian doctors, because many times in the past I've heard that there is a lot of clinical studies but they are done in Europe in different conditions, and we want to change that. So these are some of our first few projects.
So
where
it
we have
is
been
not
able to
that
do that.
he's promoting his company or because he's working for that company. What he's showing is the evidence based that those technology which is being provided by a particular agency, it is being tested. And because it is being tested on those patients, it is the right time for us also to utilize that knowledge on our patient. Am I right, sir?
Absolutely, absolutely, sir. And that's the way we want to continue collaborating with you to establish this evidence further more and more. But we also want to collaborate with you on more patient-centric things. So I just have put some photos from our past activities of awareness for patients in diabetic foot. We have done a few walls of awareness, a bike rally in Bangalore where we stopped at every community center along the way, some media events as well. And I think it would be nothing. Diabetic foot ulcer is still something that gets referred very, very late, and the patient is already in a complicated condition by the time it comes to you. Same for many other wounds, many other type of wounds. So we would love to continue partnering on awareness initiatives.
So we will also do this kind of a rally or awareness. If you are there with us, we will bring the entire college of C. We have an entire resident whosoever is interested. As you said, the idea is to generate the interest. And once they are aware and generate, they will say, where is the information? Then they will come here.
Exactly. Then they will come here.
Then they
And
will-
today we are educating for, today we are taking the course for tissue viability program, which will cover in depth how to deal with wound care, how to tackle the challenges of wound care, which product, which technology to use at which time, how to deal
Same
with.
photo we will have at the end.
Absolutely. So the next time I do a program, I will have a photo of Jipmer team there.
Thank you.
Absolutely.
Because each and everybody has taken time out of their working hours. And
Certainly.
then they have come. And I told, please don't, you are not allowed to leave in between except the restroom. Lunch is provided, snacks is provided. So you are in a flight, now this flight cannot be opened. Am I right?
And there is
Those who are not interested, please join online. Whether you are looking, you are listening, you are understanding, that's not my concern. But still we will give them participation certificate. Okay, they showed some interest at least.
So indeed, so I think that summarizes it. I hope I was able to tell you why we are doing that, and I hope that you will really enjoy this course together. So have a great tissue ability program today. Thank you very much, and we will keep interacting throughout the day.
Thank you very much, Pradeep, for have a seat here.
Sure, sure. Thanks.
Now, as I told, our first speaker is Emilio, and you will speak on behalf of Emilio, or you will play the video of Emilio? Yeah. Okay, so then should I introduce you also? Oh, lovely. So then there is our PPT. Hey, Ishak, we will introduce all the. No. Hey, Ishak, come. Minimize this and show our introduction of other speakers. Or what I feel is, why don't you introduce yourself? That is better. She will say, I am the qualified, registered, experienced. So I have given the introduction. Correct? So qualified, registered, course coordinator. This one. This one. Photo is matching. Photo is matching. So she has a 15 years of experience and dealing with all this kind of courses and throughout the India and abroad also. So I have introduced with this short. Of course, she is a registered and also MBA. Okay, madam, welcome you. And similarly, Venugopal, 11 years of experience. Clap for them. They are also the same team with the MLU dealing with the tissue viability program. This I wrote it just for those people who are online, because physically we are here now, we can always talk to each other. Already I have talked about the Emilio. So with this introduction part is over. And okay, so let us now over to back to Priyadarshini. She will have some talk and followed by actual talk of the Emilio. Over to you, Priyadarshini. Yes.
Welcome all of you. Myself, Vyula Priyadarshini. I work as Medical Affairs Manager for Urgo Medical, and I have Venu with me, who is my colleague. So, yes, tissue viability. I really don't have anything so new to discuss about tissue viability. Already, doctor has covered, and why we are here has been already discussed by Pratik. And yes, before starting on to the original course, the training part, we would like you all to take a pre-test and no paperwork and all that. It's just QR code scanning. So scan through your phone, do the pre-test, and after that, immediately we'll go on with the session.
Some pre-test I also did, but now it's actually official pre-test. Yeah, I usually.
Yes, you have done it orally already.
Yeah, orally only.
Once you're all done, maybe you can tell us and we'll go on with it.
I was not knowing that you are bringing pre-test. So I did that, but actually you are having official pre-test. It's not. Okay, so you want to know at what level. We have for testing your knowledge.
Yeah, exactly.
It is just a part of the curriculum that we must have this.
And we have post test also, post this session, so that the knowledge course will be evaluated.
Yes.
If there is any glitch in scanning the code, maybe you can take our help. If you're not able to do it
Suppose
through your
you can give your mobile, they will.
Yeah, you open Google, find a camera, Google search bar.
Open the Google and in the Google, on the right side of the top, you see search button. Camera symbol, camera symbol. Click the camera.
into the link and submit your answers.
How many questions are there? 10 questions. 10 only. So it will take 10 minutes maximum. Okay, that's fine. That's what we take less time because it is not the
Questions for a minute.
computer is not evaluated. It's not available. It is supposed to code the compound after which develop. You
And after that, we are good to start.
whether you do complete or not, doesn't matter. So if you don't know why,
If you complete only, they can able to submit. So
otherwise, you just click left, right.
it's up to you. So if you answer every question only, you can able to submit this. If you
Because
don't
all
know
the
for
questions are
answers,
come.
you know, you are new to the issue. If you don't know also,
Submit with your names without fail so that we compare later with your full name. You're all done? Please tell us. Everyone is done? You're all eyes off your phones, then we'll start. Then it won't become pre-test. You're done? Yes? Okay. Thank you all. Thank you all for doing the pre-test. Yes. So we had a bit of ice breaking already because there was nice introduction which was initiated by doctors. So we had a kind of ice breaking already. But then there's this new trick of quiz that which is conducted to a group of people. Even when we know that the content is not as been educated to them, or even though the content is not being aware to them. Okay. So this is some kind of questions that we are going to discuss here to know the impact of evidence-based practice, to know the importance of why innovation is, why there is innovation in wound management. Yes. So in that aspect, yes, we are going to have this question answer discussion. Of course, these answers would not be known to you, but with guesswork, you are going to answer. You understand? With guesswork, when you do, automatically, like the answers will get registered in your minds, and also you will know the importance of the innovation and the importance of evidence-based practice in wound management. Clear, all of you? Yes. So how many clinical trials Urgo Medical has performed since 1997 date the medical department was created? Just a guesswork so that you will remember and you will know the importance of the innovation and EBP, evidence-based practice in wound management. Yes, any guess? Any guess? Many of you said, and I'm not going to give chocolate to this. Don't give because many of them said answers. Okay. Yes, more than 80. This is to tell you that yes, Urgo Medical has performed more than 80 clinical trials from 1997. Yes. And yes, why so many clinical trials? Because we believe that QRC process is very, very important for bringing any innovation in wound management. Yes. As already doctor said, we are not dealing with wounds. We are actually dealing with the life of the patients. So that is why this QRC process is very, very important to it. The qualification study to ensure the safety of the product, and then to understand the robot, we do randomized control trials, and to understand the consistency of the solution that we bring for the patients, we also do observational studies. So this qualification, robustness, and consistency that we do through our non-comparative trials, our clinical randomized clinical trials, and our observational studies, this QRC process is very, very important to us. So you definitely see we are also here to share a lot of information. So all our clinical trials and whatever studies we are doing have been published in renowned journals like Journal of Wound Care, Lancet Journal of Endocrinology and Diabetology, and so forth and so on. And you have Wounds International, Wounds UK, and all these journals, our clinical studies have been published. So what is the common point of all these trials? Why these many trials, and why understanding trials is important, and why Urgo Medical is standing so different and standing so out in evidence-based practice? That is because of the innovation. So the first sequential treatment, the double-blind trial, and doing the double-blind trial involving ischemia. So involving ischemia, or assessing or diagnosing the ischemia. So all these has been done for the first time with our clinical trials in Urgo Medical, and the indications, the niche indications like neuroischemic, epidermolysis bullosa, pediatric wounds. All these are some examples I have taken here. So this kind of niche specialties we have taken and done clinical trials, and this innovation is actually making Urgo Medical stand out. Yes. And okay, what was the first double-blind RCT performed in neuroischemic diabetic foot ulcers? This is not only in Urgo, worldwide, like this is the first double-blind RCT that has been performed purely with neuroischemic diabetic foot ulcer patients. So what study is that? Because we will be, Urgo Medical always talks about the study a lot, and we will be talking a lot in coming days. So it's Explorer study by Edmonds. And Explorer RCT. To highlight a bit on Explorer RCT, as I already said, this is the first study where all 240 patients are neuroischemic diabetic foot ulcers. There are many studies where neuroischemic also could be a part of the study, but this is the only study where we had all 240 samples to be neuroischemic diabetic foot ulcers. And for the first time, you all know Lancet journal, right, with the highest impact score worldwide. So in Lancet journal, the very first wound care study was published. So that is nothing but Explorer with the product named Urgostat, TLC NOSF concept. Yes. So Urgostat is the first wound care study to be published in the Lancet journal in 2018. Yes. And we have got recognitions from NICE guidelines, IWGDF guidelines, and it didn't stop only with 2019. It continued to 2023 also. Even last year, we were all very proud, and we are still proud to say that even in 2023 guidelines, IWGDF guidelines, International Working Group for Diabetic Foot. So it that it actually promotes the profile of diabetic foot ulcer along with DFoot International. Some of you would have heard about IWGDF guidelines, and whoever has not heard about it, kindly go back and see what is IWGDF guidelines. So IWGDF guidelines and NICE guidelines are the guidelines which are continuously recommending the use of TLC NOSF dressing in the neuroischemic diabetic foot ulcers and other diabetic foot ulcers which are difficult to heal. So TLC NOSF is the component of the product called Urgostat. So anyways, today we are not going to talk about products, only the technology I would like you all to know, and then it is purely clinical part that we are jumping into. Yes. And how many questions the 7 interviewers of this is to know like how important and how it is super critical to get into Lancet. So a study to be published in Lancet, you all must be already knowing about it, but then just to bring some highlight about it, how many questions the 7 reviewers of Lancet, I mean the director of directory editorial asked us before accepting the manuscript. Yes, very good. 128. Yes. So 128 questions had been asked to get the Explorer study into the Lancet journal because it's the first wound care study, as I already said. So since the first NICE guidance publication in 2019, how many articles on TLC NOSF dressings have been published in peer-reviewed journals? Yes, more than 70. Okay, yeah. So more than 70, it's a big number. So after NICE guidelines, because something told by NICE guidelines, something recommended by IWGDF guidelines, the weightage, just imagine how the weightage would be. So more than 70 peer-reviewed journals, the studies have been published. And TLC NOSF, so always we say like, it's not just the efficacy of the solution these journals are talking about. We also have some journals, we also have some guidelines like NICE guidelines, which is also talking about the cost effectiveness. When TLC dressings are put on the patient, when TLC NOSF dressings are put on the patient, how effectively the cost has been overall reduced for the patient because the healing time is faster. When we reduce the healing time, automatically we reduce the cost for the patient. Yes or no? It's not just the cost about the dressings, it's the overall cost for the patient, right? The transport cost, the everyday coming to hospital cost, the treatment, the overall treatment that he takes around wound part, and then we are also increasing the ability of the patient to go for work earlier. Okay, so overall, it is very cost effective. So it is not only the efficacy that has been discussed in guidelines, it is also the cost effectiveness, which is discussed in many guidelines, for example, NICE guidelines. And just for an example, I would like to show this, the pyramid of evidence. You all must have seen this pyramid of evidence where it starts from meta-analysis and systematic reviews, and on top always the golden standard of trials is double-blind RCT. So from double-blind RCT until down till expert consensus and opinion, the pyramid of evidence has been filled with evidence for just one product, that is Urgostat, TLC NOSF, which reduces the MMPs and reduces the healing time for the patient. So why we are talking about this is how Urgo Medical is working. So we want this robustness. If we don't have this robustness, we won't bring those solutions to your patients. Yes, so this is how we are working. And how many observational studies, including more than 500 patients each, would the Urgo Medical had performed in last 20 years. it is more than 30. Okay, so totally we have done observational studies, including patients more than 5,850 so far. So this is to again highlight that, yes, we are doing observational studies to check on the consistency of the solutions that we bring for your patients. And that is how we all make you to trust the products and the innovations that we bring for wound management. So last but not the least, Urgo is a human adventure because we just started with PLC technology, and then we are into the niche specialty and bringing the specialty wise solutions for your patients. So having said this, training endorsed by Australian College of Nutrition, and we are also looking to get a learning management system, which is LMS, and a virtual. So this is a great breakthrough that we are looking. Who's going to talk about the introduction on tissue viability program and the evidence-based practice to
Good lecture.
Laughing.
பண்ணலாம்.
At the right time is really, really important. But as will be discussed during one of the sessions of assessment. Assessment is quite big. Understanding that we need to take care of the whole patient rather than the hole in the patient. What is causing healing not to happen as we would like it to happen? So definitely understanding what is going around, doing a proper assessment, again, following evidence-based practices of utmost. Doing a proper assessment, again, following evidence-based practices of utmost importance. If you have to think about barriers to wound healing, the first thing that we usually think about is thinking about the biology. Is there lack of circulation? Is there lack of nutrition? Is there infection, etc., etc.? But remember, a wound is part of the patient, it's part of a family. Understanding that we need to empower the patients, to give them as much knowledge as possible, to give them as much know-how of how to take care of themselves and how to manage their wounds. The other issue is the education or lack thereof when it comes to wound care. Because unfortunately, I think it will make sense if I say that we don't know what we don't know. However, it is even more dangerous when we think we know what we don't know. Do we understand the real research? Do we actually know the research that is behind wound care? What we will discuss today during the evidence-based practice session is how to understand the research of evidence and then transform it to our daily practice with our patients. There is unfortunately the negative attitude to this evidence-based practice. We've been using something, we think it works. The issue here is that we should not think it works. We should know exactly that it works because of all the evidence behind it. And unfortunately, sometimes we also find lack of practices, lack of guidelines in the hospitals. If a diabetic patient comes into our hospital with a diabetic ketoacidosis, we follow an exact protocol, don't we? So what happens when a patient comes in with a diabetic foot ulcer? Do we have the same protocols? Do we start arguing between the podiatrist, the nurse, the doctor, what should be done? Sometimes talking about lack of resources. Yes, it is a reality. However, do we prioritize getting the proper wound care tools that we need in our hospital? We are going to talk about costs as well today when we are talking about evidence-based practice. Understanding that the cost of the treatment is what is important rather than the cost of the dressing that we are buying. So let's get down to the business that we are talking about today, talking about evidence-based practice, understanding how important evidence-based practice is. Unfortunately, when it comes to wound care, and this is sometimes why we call ourselves the Cinderella of medicine, is because in any other practice, you have to follow evidence-based medicine. If you're working in a cardiology department, you do follow international best practice guidelines. There are the protocols that tells you what to do, what not to do, when to do it, when not to do it. Is it available for wound care? The answer to that is definitely yes. We have a lot of best practice statements, we have a lot of best practice guidelines out there, but unfortunately not everybody follows them. We base things on maybe on what we think we know rather than what is actually the truth. For example, if you're dealing with a diabetic foot ulcer patient, have you gone through the last guidelines that came out from the IWGDF, the International Working Group for the Diabetic Foot? We had a wealth of information coming out just a few months ago. Are we aware of them and are we implementing them for our patients? Because sometimes the way we make decisions in wound care is not the correct way. Unfortunately, many times, if we are talking to nurses, they will tell you, well, the consultant told us to do something and we did it. What is the knowledge of the consultant in wound care? And are we sure that that thing that is being asked for us to do is based on evidence-based practice? How can we challenge it in a correct way? It's by having knowledge. You can only share knowledge to get the best treatment for the patients, not reverting to fighting and creating a situation in front of patients, but rather doing it in a professional way. Is it what we've been using for a very, very long time? If I remember when I started nursing many years ago, we used to treat wounds with hydrogen peroxide. We used to use Uzol. We used to use Dicam solution. We know now that it's not correct. That is why evidence-based practice changes what we do. Because if we thought that Uzol helping granulation, nowadays we know that it's cytotoxic. It's a chemical that burns the wound. The same with hydrogen peroxide. You use hydrogen peroxide on the wound, you see that bubbling effect, and at the end you see that the bottom of the wound has become gray. Of course, that is a chemical burn. What is available, what I said before, do we fight to get our tools there? And tools, we're not just talking about the dressing, all the equipment that we need to take care of the patients. And not just having the tools, but knowing how to do them. For example, one of the basic things that we check for our patients if they have an ulcer, their leg is doing an ankle pressure index. Do we have a Doppler to do it? Do we have the knowledge how to do it? So it's trying to understand which dressing to use at the right time, on the right patient, on the right. We've been talking about evidence-based practice for quite a while. A huge boost was given in the early 1990s, where Dr. David Sackett came up with this very interesting and very rich definition of evidence-based practice, using the conscientious, explicit, judicious use of the best practice when we are making our decisions. And you know what? This guy actually practiced what he preached. He used to go with a trolley when he was doing his ward rounds in the 1990s with this very old laptop and would choose still floppy disks. Probably many of you don't even know what are floppy disks. And he actually made changes in his decision according to what he was finding whenever he was in doubt. So again, as we were talking previously, getting all that richness of information, how are we going to combine it with our expertise and with our clients' values? That actually came to bring about a change. Before, we used to talk in the beginning, the three-legged stools of evidence-based practice according to David Sackett. Nowadays, we realize that's actually not a three-legged stool, but it's actually a funnel, because all goes down to our patients. What is the best practice out there? What is happening in the rest of the world, but also what is happening in our own country, which gives us the knowledge of the efficacy of what we are doing? And we'll explain it more simply in a few minutes, don't worry. Looking at systematic reviews that we will explain later on as well is very, very important. Rather than doing all the research ourselves, clinicians have gone together through a board, did their own summaries and gave us their reviews for effectiveness, combining them with our own clinical expertise, combining the international expertise and the local and regional expertise together. Taking all of that, presenting it to our clients, giving them all the information will definitely help them in giving them that informed consent, that empowerment that we have been talking about so much.
Thank you, Emilio, for the briefing about evidence-based practice. If my voice is audible? Hello? So I hope Emilio has told us evidence-based practice is very much important for change and how to filter the evidence-based practices at the last he explained. So we have multiple level of evidences. We need to understand what level that evidence belongs to, and then we need to analyze and we need to implement it in our day-to-day practice. So to understand that, we need to understand what are the top level researchers and what are the base level researchers. We need to understand evidence-based pyramid. So I hope at the starting of the session, we will have shown a evidence-based pyramid. So here I'm showing it on the screen, where you can see top level of evidences or guidelines, followed by meta-analysis, RCTs, cohort studies, case control studies, case reports, and in vitro studies, which are animal trials. Okay. So we'll go one by one. Before that, I need to highlight one point. So to conduct an RCT, a big study, we need more manpower, more money, and lot in a big way. Is also matches the highest level of evidence. Okay, that is what drug has been used in JIPMER, and all of evidence to the top level evidence. Randomized control. I hope most of MSc nursing students are here. It is very much important for you in the second year to do the research. Yeah, why we need innovative methods, which saves HCP time and patient recovery time will reduce us. All these are the changes we are understanding from the evidence-based practices and implementing it to our patients. Okay. So as we see now, top level of evidence is guidelines like NICE guidelines, IWGF guidelines, Indian Diabetic Food Society guidelines. So all these guidelines will be considered as the top level of evidence. And upon below that, we have meta-analysis and systematic review. So meta-analysis is compiling of statistical information of the multiple researchers. For example, 22. For example, I'm giving the number also will be more. Okay, less or more or less. Okay, 20 researchers are there conducted on UrgoStat, and this 20 researchers statistical information has been collected, and this statistical information is compiled and producing the single statistical data, which is equivalent to the 20 studies, is called as a meta-analysis. Okay, and as well as systematic review, the literature of the 20 studies has been compiled and giving one literature based on the 20 studies. 20 is an approximate number I'm telling, it may be more or less. Okay, so this is systematic analysis. So where they are showing a great, this will show great effect on evidence-based practice because they are compiling n number of studies to produce one day. Okay, next is RCTs. So RCTs means you know very well, randomized controlled trials. So we have multiple designs in RCTs, which is a single blind and double blind. So where we have two groups in this RCTs, one is control group and other is experimental group, where we'll give intervention for the which group? Experimental group, and control group will be not given intervention and will be observing the control group, and both scores has been come. Okay, and as we quoted on the starting, we have published the article on the Lancet, which is double blind RCT, What is double blind and what is single? Very good. Yeah. So single blind is participants don't know what we are giving and researcher will know. And in double blind, both people don't know what they're giving. So the double blind RCT will be having greater value because there is no bias happening. Okay. So next is observation studies. So observation studies means we'll give intervention to the patients and we'll observe for a particular period of time. Maybe it may be days, months, years, or till the end of the day. Okay, observation study means we are giving the intervention and we are not taking control of the patients. We are just observing, most probably real life studies. Okay, so here also we have retrospective studies and prospective studies. So very well. What is retrospective? Yeah, going back in time and understanding some concept, understanding our interventions, and the intervention related matter is called retrospective. Prospective means giving. Very good point. So next is case reports. See, the researchers, as I told you, a drug is having RCT support and meta-analysis support, and it has been implemented in the guidelines. So we cannot able to, in some setups we cannot able to invest that much money and that much manpower. In this scenario, I am taking that Urgostat product and I am checking it on 10 more patients in my clinic or in my hospital. Okay. So after applying Urgostat on the 10 patients, I am getting same effect what has been shown in the meta-analysis or RCT or in guidelines what they have done. Okay. So then we will consider it as a top level of evidence. It is not acceptable, I am telling, for our understanding. See, this is mental preparation of ours. Theoretically, we cannot able to put it in practice. See, yeah. For example, I used Urgostat. Guidelines is telling us 100 days wound has been healed. But I applied Urgostat in my patient, and I have seen with my own eyes it happened in 60 days. I cannot able to change that RCT result because it happened in 60 days. Just I am getting the same results what has been shown in the RCT. So I will feel that this dressing is very effective, and I'll implement it. Why I am getting that consensus? It has top level of evidence, and it has been seen in my patients, in my case. That is what I'm trying.
It's a beautiful term that you use, consistent. Yes, so that is very important. In our cities, we are controlling some samples. Yes, we are giving intervention for the one group, and we are not giving intervention for the other group. We are controlling, but in observation studies, we are not controlling. So when it comes to case reports, same like that. We observe and we see like what is happening, but then we are not doing it in a big way like observation study. We are just doing a case report or a clinical case study. That's it. So you understand? Yeah. So it is a supportive. So that is more than enough. You do a clinical case study and you understand the consistency and you understand the reliability. So that's more than enough. So then it has got value. So it is for us to understand. Then it has got value. But then yes, in the pyramid of evidence, it is in the last place. Yes, but for the reliability and consistency and to trust upon a drug, yes, that is important.
Thank you, Vila. And next is expert opinion. So where an expert will give a talk on particular dressing or particular drug which was showing its effectiveness. And anecdotal records is by observation. As a nurse, you are standing beside the doctor and you are observing 10 to 15 patients which has been treated with the particular dressing. And you are giving some consensus about the dressing, then it is called as anecdotal, which is on the lower level of the evidence. Okay, about this we have in vitro studies. Which has been conducted on the animals or in the laboratory. In vivo studies which has been conducted on animals and in vitro studies which have been conducted inside the laboratory will be having the lower level of it. Clear? And coming to the as we have concluded the topic before itself, for a change we need innovation. And who will bring up the change? When you understand the evidence, when you understand the product, you are the people who are bringing up change in the patients in your setup, and you will save your time also. You can treat multiple patients. Okay, by this we are ending the session with the one single quote. Innovation is an ability to see change as an opportunity, not a threat. Okay, so when you can say it is not a threat, if you understand the evidence back of that, if you understand the research back of that, then you can say it is not a threat. Okay.
And also when you improve the quality of life for your patients, then it is not a threat to any of them. Yes. Okay.
Okay.
So, so we will break for lunch now. I think.
So those who are online participants will have a break here of 1 hour. And now it is 1:20. 2:20 we will again accept. Assemble by 1:15 here, 2:15 here, so 2:20 will start the program. With this, online viewers can also have their lunch, and we will have a real lunch here. Okay, so we close it. Chuck, okay, so for the lunch here physically, we will give you here. We have enough numbers of rooms. You can just sit in those rooms. Otherwise, you can have here. There is a arrangement in the other seminar room also, so that you can have a one to eat our next talk is by whom? Already we have introduced you. Please have a seat first. I will. This talk, no? Okay. Okay. So good afternoon once again, and welcome you all in the afternoon course, accredited course program on tissue viability. And our other faculty, Dr. Mahapatra, the professor of plastic surgery, has also come. I would like to welcome him because morning sir was busy. I request one of the participants to welcome. Welcome your teacher. Your teacher. Yeah, take a photo. Thank you. Thank you. Dr. Triji is in the OT. He will also join. So I now invite our next course coordinator, Mr. Venu Gopal. We have already introduced him. Over to you, sir.
Hi, everyone. Hope lunch is good. Yes, it was good. Okay, fine. Now we are getting inside the real topic. So morning we have seen what is evidence-based practice and how to implement it in our practice, and all these things we have seen today morning. And now we are going to see the serious content, starting from wound healing, key components, and wound assessment, which is very much important. And I have seen the publications, what the plastic surgery department has been done when I am coming out of the doctor's cabin. So I came to know that Bates and Jensen's wound assessment tool is a tool which has been used here, and the article has been published. So I hope in add on to that knowledge, we are going to discuss assessment here. Okay, fine. So let's move on to the slides. The question on the screen. The question on the screen. Okay, I need single word answers. Protection. Okay. What? Okay. It's protection again. Maintaining temperature, thermoregulation. Very good. Okay, you will see the functions of the skin here. As you said, protection, thermoregulation, metabolism, and sensory perception and release of waste. You will accept release of waste. What is the waste it was releasing? Sweat and sebum. Okay, these two waste it was. I'm not getting deep into the anatomy physiology since you all are aware about anatomy and physiology. Right? And coming to the layers of the skin, we have three layers: epidermis, dermis, and hypodermis, which is called as a subcutaneous layer. Hair follicles start from the dermis. All nerve endings, nerves will be there in the dermis. Muscles, all these things will be in the dermal layer only most. Okay, and what cells do we have in epidermis? What? In epidermis. So keratinocytes and melanocytes. These are the major cells we have in the epidermal layer. Okay. So melanocytes is the coloring pigments, and keratinocytes, we have 5 layers of the keratinocytes, 4 layers whole out the skin. In palm and sole of the foot, we have an extra layer which is stratum lucidum. Okay. So brief anatomy about 3 layers of the skin. Okay. So coming over here, now we need to understand what is wound. So what is tissue? Group of cells. What is muscle? Group of tissue. What is body? Okay. So again, so why I'm bringing this question is, so we know a continuity of the tissue is required for muscle. Okay. So when we have a break or damage of this continuity of the tissue, then it is called as a wound. So simple definition is loss in continuity of the any tissue due to any reason is called as a wound. For example, reasons we have seen trauma, infection, and pathological. Simple definition, what you can remember is loss in continuity of the any tissue is called as a. Okay. And if you see the picture over there, you can see lot many wounds which has happened to that human, right? So, so as I say, with my nail, I'm scratching over here and as well as on my biceps. Which wound will heal faster? Whether the wound happened on my bicep, whether the wound happened on my nose. Why? Only prominence. When I'm scratching here, almost I'm damaging all 3 layers of it. But here, maybe due to the scratch, I may lose only epidermis. See, why I'm bringing this point is based on the location, based on the contamination area of the body. For example, wound happen in the axilla, groin area. These wounds may stall for the longer duration because it is contaminated all. Okay, so based on the different locations, wound healing will be different. Okay. So next is wound healing. So now in before slide we understood what is wound. Loss in continuity of the tissue is called as the wound. To fulfill this loss, what has happened to the tissue, body needs to undergo several physiological, chemical, and biochemical changes and number of cellular events, which is called as a wound healing. Okay. So what are the phases of wound healing? Can anyone tell me how many phases we have in wound healing? Inflammatory phase, proliferation phase, so granulation, remodeling. Okay, 3 layers. Okay, very good. Give a clap for you all. Seriously. Okay, fine. So we have 3 phases in the wound healing: inflammatory phase, proliferation phase, and remodeling phase. Then what is hemostasis? Okay. Okay. The pre-inflammatory phase is called as it's a part of inflammatory phase. See, a lot of confusion is that people may say 4 phases. Some places where hemostasis is considered as a separate phase. No, it is not. It is a pre-inflammatory. Okay, it is a part of the inflammatory phase. So I have in the screen you can see major events what was happening in the 3 different phases. So one by one we'll go on. We'll see what was happening in that phase. So as you know, wound. What is wound? Loss of content of the tissue. So now some reaction should be happening at the damaged site to fulfill the loss. Okay. So now first it will start with the hemostasis. Where hemo means what? Stasis means stoppage or slowing down. So in the word itself we have a meaning here. So blood stoppage or slowing down is called as a hemostasis. Okay. So here what cell in our body is doing that action? Blood platelets. Blood platelets in our body is playing major role in the hemostasis, in the clotting. Okay. So blood platelets will release as platelet derived growth factors, which is called as a PDGF, which will initiate inflammatory responses. So what are the inflammatory responses you will see? Rise in temperature, erythema, edema, okay, redness, erythema, okay, then pain, very good answer. So all these are the inflammatory responses what you will see when wound happens in our body. Okay, so and to reduce the loss, permeability of the tissue will also increase of the permeability of the capillaries you will see. Indeed, it will increase the exudate level also. Okay, so now macrophages and fibroblast cells, all the wound healing cells which will do major action in the wound healing process will be brought up to the site of the injury. This will happen in the hemostasis. So blood slowing down, stoppage, bringing up the inflammatory triggering factors, inflammatory responsive cells to the site will happen in the hemostasis stage in brief. Now coming to the inflammatory phase. So what happens in the inflammatory phase? So inflammatory mediators come to the place, and then as we have discussed, the permeability of the capillaries will increases. When permeability of the capillary increases, automatically X-rate level will also increase. So X-rate level will increases in the wound site, and as you said, inflammatory responses will triggers where you will see rise in temperature, erythema, all these things. All this will happen in the inflammatory phase initially. Now, the cells which has been brought, macrophages, which is a part of the WBC, and neutrophils, which is a part of the WBC, will start acting on the responses which was happening at the wound site. Okay, so macrophages start phagocytotic action, which is engulfing the foreign bodies and our own body damaged cells. Okay, this happens at site, and neutrophil starts the first line of defense against the infection process which was happening in the site of the wound. Okay, and clearing the dead particles and as well as engulfing the damaged cells and blood clots will happen in this inflammatory phase. Okay, when it happens only, the cells will have a space to proliferate. If infection or the dead cells which are there in the wounded area, if they are not cleared, proliferation will not. Okay, so clearing of the dead particles and foreign bodies is required in the inflammatory phase. If it is not done, the wound healing will not go to the next stage, which is called as a proliferation phase. So now here, proliferation phase. So you know very well, collagen is very much important in wound healing process. So what cell in our body is producing collagen? Fibroblasts. Okay, so fibroblast cells are the basic cells, very important cells which are producing the collagen in our body. Not only collagen, elastic fibers. So when doctor is talking about 4 C's during the starting of the session, he has told us about the tensile strength of this skin, contractile, which is called as a tensile strength. Okay, so here collagen fibers will act as a scaffold. Scaffold means a support for our tissue, and elastic fibers will give the elasticity. Okay, the stiffness of the skin is due to the collagen fibers, and the elasticity of the skin is due to the elastic fibers, which is produced by the. Okay, so now here, how collagen is helping for the wound healing. For a construction of the building, how much important a pillar is. In the same way, collagen will act as a pillars for the supportive cells, for the blood vessels growth, angiogenesis growth, for the supporting the cells to build up on some structure will be happened by the collagen. Okay, so now fibroblast cells will release the collagen fibers, where it will act as a scaffold and support all other cells to grow and proliferate with angiogenesis also. Okay, angiogenesis also will take support of the collagen fibers and will. So now migration of the fibroblast. If you see in questions what have been asked at the early morning, so all the questions what we have taken in the pre-test, you will find answers here. Okay, in upcoming slides you will get the answers. Why I'm telling this point, I'll tell you in upcoming slides. So migration and proliferation of the fibroblast cells is very much important for the production of the collagen. So if collagen is not there, proliferation will not be. Okay, that you keep in mind in this case. Okay, so next is and as well as in this stage, proliferation stage, when phagocytosis is happening and wound bed is clearing, automatically the cells will proliferate and fill the wounded area. So after filling the wounded area, and not only filling the wounded area, it will provide a support for the epitheliation to happen. Epitheliation means, so for example, wound happen like this. Proliferation will happen like this, and epitheliation, epidermal cells will grow like this. Not only from the wound edges, epitheliation will take place, but also from the hair follicle end, epitheliation will take place. Okay, don't think that from wound edges only epitheliation will take place. No, from each and every hair follicle end also, you will see the epitheliation. Most probably the people who are working in the burns part, you may see that most probably in burns wounds, near each and every hair follicle, epitheliation will start not only from the wound edges. So now, in the proliferation phase, wound damaged tissue has been filled and epitheliation is happening. And in maturation phase, what will happen? In maturation phase, the collagen fibers, what has been formed, will strengthen, and the newly formed cells will regain its strength. Most of it will happen between the 14 to 21 days after wound happens. And as contraction, what doctor has said, if you compare the before tissue, the tensile strength of the before tissue is 100%. After wound healing, the tensile strength will reach maximum up to 80%. It will not go to the 100%. Okay, multiple studies have been proven. Okay. So I have a nice video which will show you a summary about all the three stages or three phases what I have discussed. Please be vigilant and watch it. Fine, guys. So video is sorry for that. So I'll give summary upon that. So hemostasis, where blood will slow down or stop, blood loss will be stopped with the help of the blood platelets. All inflammatory responses will triggers in this phase, and inflammatory mediators will be brought to the site. Sorry, in front. Sorry, fibroblast cells and as well as macrophages, all wound healing supportive cells will be brought to the site of the injury. This happens in the hemostasis and followed by the inflammatory phase. Where majorly
அப்புறம் ராகுல் என்ன மகேந்திரன் அண்ணா நான் பாண்டிச்சேரி
cells will proliferate and migrate and multiply in number and fill the wounded area, which will happen in the proliferation phase. And epitheliation will take place from the wound edges, not only from the wound edges, from the hair follicle ends also, epitheliation will start. Epitheliation will take place. And post that epitheliation, remodeling phase will start. So most probably it will start between the 14 to 21 days period after wounds happen. So here the newly formed collagen and newly formed cells will will regain its own strength, which will continue till up to 6 months also it will happen. And the regained strength will be not matched with the previous cells. So approximately the tensile strength will be 80% from the maximum. That is the outline what we need to get from this wound healing phases. Okay, so why wound healing phases is very much important to understand the different type of which stage they are and what treatment we need to provide for the type of wounds. We need to understand the wound healing phases very much. Okay, so in next slide, you can see normal versus impaired wound healing. So in left hand side, if you see, there is a normal wound healing left hand side in the screen. So you can see epitheliation is happening, scab has been formed, and as well as the angiogenesis is happening, and proportion number of the macrophages are there, fibroblast cells are there, all things are right in number. Okay, so now coming to the right hand side, on top, if you see the part A on top, it is biofilm. So bacteria which is protected with some jellified structure, which is known as EPSC, protective layer, which is known as extrapolymer substance, is known as a biofilm. Okay, so what happens in inflammatory phase we discussed? Our own body cells, which are macrophages, in depth if you go matrix metalloproteases, these proteases need to go and clear the bacteria. Okay, but the bacteria cannot able to penetrate inside the biofilm. For example, I'll tell you, I'll put two girls outside and I lock the room. With the bare hands, if I ask the girls to come inside, is it possible for them? No, they cannot able to come inside. In the same way, our body cells will reach to the site to kill the bacteria. But the capacity of our body cells will not sufficient to get inside the biofilm and kill the bacteria. Now, what will happen is, body will get responses that inflammation still exists and it will releases more number of the macrophages and matrix metalloproteases. So when number of the matrix metalloproteases and macrophages increases, they will feed on our own body cells and they will increase the wound sizes. When wound size increases, automatically the biofilm also spreads to the adjacent areas and wound will be stalled for the longer and longer duration. In which phase? Inflammatory. It will not go to the proliferation. Once all this has been cleared, then only it will go to the proliferation. This is what's happening in the chronic wounds and non-healing. Okay, clear with that? Okay, biofilm is the main culprit. Not only biofilm, our own body cells, macrophages, in depth if we go, MMPs, matrix metalloproteases. Okay, these are the cells which are increasing the wound size and stopping the angiogenesis. Okay, and eating our own body cells. All this happen by the macrophages. In detail, you will come to know about macrophages in upcoming slides. A question here. Some are telling fruit. Anyone is telling vegetable? You go to supermarket, will you find this in fruit section or vegetable section? Why? You are telling it is a fruit. Not that big corporate companies are doing, they're keeping the tomatoes in the vegetable section. Why? Now tell me, tomato is fruit or vegetable? It's quite confusing to answer this question, right? Because the truth is tomato is a fruit only. But still, in our childhood, today also, if you open the LKG students or first time student book, it is in the vegetable section only. And if you search in Google, it was showing it is fruit. See, the transmission of the knowledge should be happen, and this the misconception what I have till yesterday should be changed is what we are saying evidence-based practice. A lot of evidence will be there why they are saying it as a fruit. Okay, so I have a similar question in my next slide. Yeah, don't say one option and I need Y also. You're selecting one option here. The person should say why you are selecting that option. we are saying dry, as I noticed in ma'am said dry, and someone here, boy, moist. Someone said moist. Who said moist? Okay, madam from the last, moist. Okay, ma'am, why you're telling dry? No, somewhere you heard or somewhere you was practicing the dry wounds in first, right? So, see, if you remember Emilio slides, how we are believing multiple things is by seeing, by listening, by practicing, somehow we are imprinting some concept in our mind. Okay, so in the same way, I too believe dry wounds will heal faster until I join Urdu, seriously. Because I'm into the cardiovascular department from my MSc and after all the experience what I have, and suddenly I shifted to the wound care sector. Till that, I believe that dry wounds will heal faster. But the right answer is why. And here my colleague here will explain why moist wounds will heal faster, and she'll take you to the wound assessment and key components of the wound assessment. Okay, if you see here, you can see 3 leaves. Which one is moist, which one is dry, and which one is wet. Okay, so if you compare this, you may understand why moist environment is required for the wound. And one more important thing is we have discussed it in proliferation phase. We need a cell which is very much important to form the collagen, which is fibroblasts. So moist environment is required for the proliferation of the fibroblasts. Okay, so if moist environment is there, it will proliferate. Proliferation of the fibroblast will be more. Okay, so from here I'm handing it over to the Beulah. She will take over.
So thank you, Venu. Anyways, the more into clinical discussion has started after lunch. So post lunch is always a very difficult time for us to put concentration, attention onto anything that we are listening to and learning. But still, I really thank this group. I'm not really seeing any sleepy faces or disinterested faces. So thanks for that. And I hope this continues until the session ends. Yes? Yes? Okay.
Lots of chocolates we got for some assessment. Okay.
Okay. So yes, moist wound management. Too much dry is also not good to the wound. Not at all good to the wound because the proliferation process is completely based on the moisture that is there on the wound bed. So the epidermal cells have to migrate further and further if the dry scab is present there, or too much of dryness is present on the wound bed. So dryness is not at all a good concept. Any problem with the Zoom? She has come. No problem. Okay, and too much of exudate, lot of exudate, which is not managed, which is unmanageable, and we are not managing it as well. So that is also not good. So moist is something, there is no dryness and there is no too much of moisture, obvious moisture is not there, but the enough balanced moisture is there in the wound bed, which will facilitate the fibroblast to proliferate further. Yes, so which will stimulate the cells to proliferate further. So that is why this concept was also this moist wound healing concept is not a new concept. It's a very, very old concept. If you look at this George Winter's demonstration, it happened like in 1927 to 1981. During his period, I mean, this demonstration has been happening. Okay, so George D. Winter was the one who actually demonstrated moist wound healing as the first person. He selected pigs, the domestic animal pigs, he has said, and he allowed some wounds on them, some wounds on some of the pigs to be open, and wounds on some of the pigs to be closed with a dressing. So then he found out the wounds which have been closed with the dressing have had good epithelialization, twice the times faster than the wounds which were left open. So what does it mean? So here it is not something to talk about the dressing. So we close and keep, and somehow we are able to trap some moisture and leave it for the wound bed. You all understand? Yes. So some moisture is always required to the wound bed. That balanced moisture is very much required to the wound bed. so that the cells will proliferate further. Yes. So he has been demonstrating this on the pig, and this picture, which is on the right hand side, you'll be able to see when there is a scab and when there is too much of dryness. So the epithelial cells are not moving further. So when there is a moist wound environment, yes, the epithelial cells are able to move further, and that is how you will see faster healing compared to the dry wound. So any wound has to be covered. For many reasons, it has to be covered to protect it from the contamination, to protect it from the further infection. Yes, to keep it very safe and to protect it from the further trauma. For many reasons, we have to protect the wound with dressing. But yes, moist wound management is also something that has been provided by a dressing. But which all dressings provided, that also matters. So which dressing? Are we really giving an ideal dressing to a patient where the moisture balance is provided throughout the dressing change? Like throughout the dressing is there and until the dressing is changed. So that also matters. Yes. So having said this, a quick question. Maybe there is something called a Pictionary or connections, connecting pictures or this kind of games, yes, that we would have definitely come across. There are 5 pictures, maybe with one picture, if you say, I'm not going to give extra chocolates, but then how earlier you find with less clues would be like you're so thorough with that. Okay. So what cell am I? Yes, a connective tissue cell. That is why I have put this. Yes. You are nearby. Connective tissue cell. Of course, fibroblast. Okay. Fibroblast. So yes, very good that within 2 clues you were able to, because we have been talking about it. And what this picture depicts, you can say the breakdown of fibrin clot. Yes, the breakdown of fibrin clot, which is for which the fibroblast is very much responsible for. And this one, finally, it has to contract into a smaller size. It helps the wound bed. Fibroblasts are also further helping the whole wound bed to contract in smaller size. And anyways, with these 4 clues, if anyone is not finding, the fibroblast cell itself is put here. So thanks for finding it out in 2 pictures. Okay. So moving on with fibroblast. Yes, already Venu has covered it. It's a very important connective tissue cell that we have got in our body. So fibroblasts are very, very important. That is because that is the one which synthesizes extracellular matrix, ECM. So within extracellular matrix, what all lie into? Collagen, hyaluronic acid, yes, elastin, glycosaminoglycan, yes, all these are present in extracellular matrix. So this extracellular matrix has to deposit and degrade. So this is what is exactly happening in wound healing process anytime when the wound is healing. Yes or no? Yes. So fibroblast synthesizes ECM, and within ECM, of course, you have all these, including collagen. So collagen is something very, very important, as already explained by Venu, that it is playing a very, very important role in wound healing process. And collagen 1 and collagen 2 are the very, very important collagens which are playing major role compared to the all other collagen types in wound healing process. Yes, you're all sure with this concept? Yes. So every time when the wound is healing, you will see the extracellular matrix is building up and then breaking down. So deposition and degradation. So building up and breaking down. Clear, all of you? So this is where it's very important that the prime cell in wound management is fibroblast, and then fibroblast synthesizes ECM. ECM has got collagen within it. Yes. So fibroblast, ECM, and collagen. So these are the 3 components which you shouldn't forget when it comes to wound management. These are playing very important role. Okay. So 4 important reasons for moist wound healing. There are a lot of reasons for moist wound healing, which we have been discussing. So specifically some major reasons that we need moist wound healing is it will speed up the healing of your skin. And we know the reason why now, because we talked about it. Yes. And it will prevent scabs. Of course. What if the scab is there? So every time when we do the dressing or every time we clean the wound, we can remove it. Like, why scab should not be there? Why we don't? What is scab basically? Maybe partially right, but not debris or dead tissue. Like completely, it's not debris or dead tissue, you should say like scab is a dry exudate that is settling upon the wound bed. Okay, of course, exudate has got debris also into it. But if an exudate that is coming out of the wound bed is not absorbed or not really secured by a dressing, what happens there? It will dry up and forms a dry crust or a spill. So we all get abrasion and laceration sometimes, especially abrasion. And after some time, there won't be, for some time, there will be serous exudate. And after some time, it will dry up and form a crust, which we tend to pick it sometimes. Yes. So that is called scab, the dryness. We shouldn't allow the exudate to dry at all. So when it dries, it forms scab. So why scab should not be there? What if we regularly like remove it with our dressing or cleaning, with our dressing change or cleaning? Why scab should not be there? Yeah, that is there. Yes, of course, it will not allow the fibroblast cells. I mean, it won't allow the epithelial cells to proliferate further because it will get stuck there because there is dryness, scab has developed. And what every time the scab is removed with your cleaning of the wound while changing the dressing, of course, it will, you are re-traumatizing the wound bed. Again, you're traumatizing the wound bed. Yes or no? So now 2 into 2 centimeter wound will become 3 into 2 or 4 into 4. Yes. So you are just deepening the wound. At the same time, you're making the size of the wound also bigger. So it will prevent scabs, moist wound management, which is why it is important. It will prevent scarring and ensure beautiful healing. So the quality of healing also will be very much better throughout the wound management process if you maintain balanced moisture to the wound bed. So scab formation will be very much reduced and you will see a quality healing. And moist wound healing is skin friendly. Of course, it's very, very skin friendly. Throughout your pain will be really subsided because every time your dressing is not going to pull out your cells and it will traumatize and give you pain. And as sister already said, the traumatizing and deepening the wound, all these will be avoided. So overall, you'll have a very, very skin friendly wound healing process. So for all these reasons, moist wound healing is very important. Okay, moist wound healing overall prevents tissue dehydration and death. Yes, because when there is a scab tissue present, when there is a dry environment, what happens there? There is a lot of chance for the infection to happen. Yes, there is a dry environment. There is a lot of chance for the infection to happen. When there is infection, of course, further tissue dehydration and death would occur. Interaction of growth factors with their target cells. So when there is a dry scab or dry exudate that is present, that growth factors, interaction, and the migration of the cells, all these will be avoided. Okay. Helps in breakdown of dead tissue on wound surface. Yes. Moisture is there. Won't it help in autolytic debridement? Yes. Yes or no? Moisture in the wound bed helps in autolytic debridement or not? Yes. Are you all confident? Yes. Yes. Moist wound environment really helps a lot in autolytic debridement. There is moisture provided and it will activate the enzymes which are responsible for body's autolytic debridement to happen there. So what are the body's enzymes that are present for autolytic debridement? Importantly, see, macrophages, yes, it will actually engulf the debris from the wound bed. It is one of the process in inflammatory phase to remove everything from the wound bed, push it out. We have a lot of enzymes. What are the major 2 enzymes that we have? Some examples also you can give of those enzymes which are helpful in autolytic debridement. Elastase and peptidase. Yes, elastase and peptidase are the important enzymes which are helping in autolytic debridement. So those will be staying inert if there is no moisture. You need moisture for those enzymes to activate and do autolytic debridement. Clear all of you? Elastase and peptidase. Then you have few other enzymes as well, but these are the major ones. Okay. And accelerated angiogenesis. Yes, moisture is there. Capillaries will be rejuvenated. And of course, the granulation will be processed only after angiogenesis. Yes or no? Without angiogenesis, do you see tissue formation? No. Without capillaries, there is no tissue formation. Yes. Less risk of infection. As I already said, always a dry surface on the wound will attract infection. Fine. Significant reduction in wound pain, which we already discussed. Less risk of trauma, which we discussed earlier. Quicker healing is more cost effective. Morning also, we have been talking about this cost effectiveness. So we are not giving trauma, we are not giving pain, we are not deepening the tissue. We are really taking care of all these with moist wound management. And of course, the healing is going to be faster, and you're reducing many other costs for the patient as well when the healing is faster. So it is a very cost-effective wound management that you provide to your patients. Too little moisture, so significant necrotic tissue. Necrotic tissue will be there, or the slough. If there is slough, the slough will be very dry, and you have to remove the slough. If you feel the wound is very dry, then you need to provide hydration through some external local treatment. You need to provide some hydration if the wounds are really healable. And if you feel that no, this dry wound is not going to revert back, then what you will do? You'll remove the necrotic tissue. Without removing the necrotic tissue, would you be able to find the damage of the depth of the tissue? No, you will not know, because it is already hiding and you will not know what stage it is. Yes. So when the necrotic tissue is present, you will have to debride. And when slough is present or when the wound is dry, you will have to provide something locally to hydrate it. Yes. And too much of moisture, the right opposite one, too much of moisture. What's happening on the peri-wound area? Can you see the, yes, maceration? Can you see the white color soaked, boggy skin? Yes, around the peri-wound area. Do you really think this is very harmful to the patient, or it can be just there and you can take care of the wound only? So what are the harmful effects when there is maceration? Beautiful. It will increase the size of the wound bed. Again, as I said earlier, 2 into 2 wound will become 4 into 4 in some days, because the macerated area is a very, very fragile area. Again, it will break down, merge with the size of the wound, and wound size will become bigger. Yes or no? So maceration is very, very harmful. And if the unmaceration is not happening with a real good water there, yes, it's happening with the exudate of the wound bed. Yes or no? So the excoriation part and harboring the infection, microorganisms part, everything is going to be higher. The risk is going to be higher when there is too much of maceration. Yes, wound infection continuum now. So how does an infection start? And what is contamination, colonization, local infection, spreading of infection, and systemic infection? Anywhere you see a wound is infected, this is how it will start with. Yes or no? It will start from contamination, and then it will move on to colonization, then to local infection, then to spreading of infection, then to systemic infection. So what exactly happens here? What is the difference between colonization and local infection? Colonization and local infection. Yeah. So it will form colonies, and the microbes will form colonies. But do you see tissue damage there or not? Yes or no? No, there is no tissue damage in colonization, but the wound has been exposed to microbes now. You're all clear? Yes or no? The wound has been exposed to microbes. Microbes have started developing colonies and they are ready to really infect. Okay. So colonization time, you see the microbes to be present, but then the tissue damage hasn't happened. Clear, all of you? Yes? Okay. And then in infection, you see the microbes to be what? Multiplying. You see the microbes to be multiplying. The virulence will be more. And you clearly see a sign of tissue damage locally. Okay. So that is where you call it, there is local wound infection. There is wound infection locally. Okay. And then spreading of infection. What is happening? A wound, a diabetic foot ulcer, which is on the dorsum of the wound, has been infected. And now you are finding it to be spreading infection. So what all you see there? What it means like spreading infection? Beautiful. So it moves further and forms a swelling in the ankle, and then too much of pain, tightness on the skin. Yes, all these will be there. And you can also suspect in the underlying tissue there is infection and pus and everything. So now it is spreading. It's not just sticking to the dorsum alone. Okay, now it is spreading. So then you call it spreading of infection. It enters the bloodstream. Then it becomes systemic infection. Then a lot of treatment methodologies will come in place. Okay. What about this biofilm that Venu has been talking about? What is this biofilm? Mhm. Okay, okay, yes. Now I have one question. Biofilm forms in colonization or not? I've given a question mark there. So you tell me now. Biofilm forms during colonization or it forms only in the local infection phase? Beautiful. During colonization, it starts. Okay. The virulence of the biofilm will not be seen during colonization. We will not be able to see it with our naked eyes for sure. Okay. But then slowly in the local infection phase, you will start seeing the biofilm present. Not only the clinical signs, sometimes the visual signs as well. Yes. And we will be talking about it. Okay. So how to identify the risk of infection? You really have got a lot of factors to identify the risk of infection. Comorbidities, when you talk about diabetes, immunodepression, malnutrition, obesity, respiratory diseases. And when it comes to medications, corticosteroids and immunosuppressants, all these will aid for risk in developing an infection. Hygiene, patient who are treated at home because we are not able to supervise, they might do anything to contaminate their own bed. Yes. So these are all the main general reasons, like these patients with wounds are at the risk of developing infection. Are you all here? Yes. Okay. And then what could be the other factors from own point of view, from own characteristic point of view? What could be the other risk factors for a wound to develop infection from the own point of view, wound's characteristic? No, no, no. I'm not asking what are the signs. So I'm asking what are the wound characteristics will be the predisposing factors for a wound to develop infection? Beautiful. Location, where it is present. There is a sacral pressure ulcer. It will be constantly infected. It will be constantly contaminated. Yes or no? Because of the fecal matter. Yes. So sacral pressure ulcer as an pressure injury, as an example I'm giving here. So location of the wound matters a lot. And then any other local wound characteristics? Okay. Yes, yes. Because the protective layer is completely lost. And yes, that also could be nature of the wound. Yes, the nature of the wound, location, and age actually comes in the patient's characteristics. I'm just talking about the local wound characteristics. Yes, chronic wounds. Chronic are more likely to develop infection. Why so? Because they are in nature will stall for a very long time in inflammatory phase itself. Yes or no? Yes. Okay. So chronic wounds are very, very prone for infection compared to the acute wounds. Open up. I'm just listening to all your murmurs very carefully and taking answers from you all. Okay. So more than acute wounds, yes, chronic wounds are very, very prone to develop infection. And location, as you already said, and size. What if the surface is very, very big, large surface, and depth? If it is so deep, what are the complications that we could predict? And they are so deep. Compartments will be formed and deep fistula and abscess. Yes, all these will be formed and yes, these all will pave way for forming infection. Elements present in the wound bed. Wound with debris. The wound always has got slough. Yes, it is 5 times more at risk for developing an infection. Dead tissue that is left in the wound bed without debriding it or cleaning it properly. But basically, debridement is for slough or for infection and biofilm. Okay, any other answers? Maybe you can say why also. Many times without cleaning, the slough will be reduced. Yes or no? Because slough is not something that you see as a big dead tissue or a very firm dead tissue only all the time. Like mucus, like strings. Yes, slough will be always present. So with your cleaning also, slough can be removed. But debridement is not always only for slough. Okay, it is also for infection and biofilm. You will also remove the dead tissue from there. You will remove the slough tissue from the wound bed, and you will also do some radical debridement. You will clean it well because you don't want the infection or biofilm to be there, and you will make sure that if these are present, if this tissue is present here, it will again give way for reformation of biofilm, then I have to clear it off through my debridement. So always debridement is not only for slough. That we should understand. Yes, slough can have many forms. It's not only a thick tissue. Many times it could be in spring. It could be in mucus-like material. Yes. So it is also for slough, biofilm, and infection removal. Okay. What is a Tilly score? Has anyone come across Tilly score? Yes? No? No? Sure, all of you? Okay. Therapeutic index for local infection. Therapeutic index for local infection. So I really think this would be helping you all, but this is not talking about something new. This is talking about the general manifestations that we assess from a wound for finding the wound is infected or not. But then when you have a proper scoring, when you have a proper tool to identify it, it will be easy for you to understand that there is infection present, and after this phase, yes, this is not falling into any of the components of this tool. So the wound is not infected. I am going to shift the antimicrobial dressing to a neutral dressing. You understand? So do you think antimicrobial dressing is throughout helpful for the patient? No. Maximum 28 days is the time that we should put any antimicrobial dressing. And that is the maximum I'm talking about. And after that, we are not supposed to put any silver dressing more than 28 days. Continue for the patient. Yes. So for 2 weeks, we are putting an antimicrobial dressing for a bit, and infection signs have subsided. But still, we'll go for antimicrobial dressing only so that it prevents infection also. So let me go for it. Do you think it is good? No, it will hinder the wound healing process. As soon as the infection subsides, or you feel the risk of infection subsides, then you need to shift from antimicrobial to any accelerating wound dressing or a neutral dressing. Clear? Okay. So for that, this tool is very, very important. Therapeutic index for local infection, and this has been published in the journal also. This is a very, very reliable thing to be followed by any of us, like not only nurses and doctors. It will be very, very easy to be understood by a layman also. In that way, specifically, 5 countries experts have come together and they made a consensus and they developed this tool so that not only health professionals, from anyone at home, if they see this tool and understand for their own family members or for themselves, they'll be able to find out if infection is there. Okay, so it is very, very easy to be understood. Therapeutic index for local infection, which is a diagnostic tool that was developed to facilitate the identification and decision making around the infection for staff of all levels, including those not specialized in wound care. Okay, so to talk more about this Tilly score was done with its validation and published in the Journal of Wound Care in December 2020. Okay, in December 2020, the Tilly score was published after the validation process. So this was developed by 7 European countries, and their consensus brought together to discuss the various aspects of diagnosing the local wound infection. So we have this Tilly score made as a tool, which I will show you now as a soft copy, like how it is used. Okay, and you will also get a hard copy. I'll ask Janaki or anyone to facilitate and bring those tools. Make sure those tools reaching you all. Okay, fine. So yes, the wheel. So this is how the Tilly score wheel looks like. So this is the study. Maybe this also I'll ask Janaki to share a hard copy to you all. Tilly score, the published article. So all the components of this Tilly score has been designed in such a way where it can be modified as a tool and used by nurses and doctors. Okay, so that is where this design came out, and Urgo found this to be very adaptable. As we already said, we are a very scientific oriented company, and anything that comes published in journals and anything that comes which is accepted by HCPs, not only other countries, our Indian experts as well, then we definitely adapt it, we follow, and then we pass the information to all the other HCPs in India as well. Okay, so we found this Tilly score to be very, very, in our medical affairs department, we found this Tilly score to be very reliable. So we thought we will take it up, and we are also taking it to other nurses. Okay, so turn the wheel to the right side and count the number of parameters present on the wound of your patient. Now I'm going to turn wheel. So in hard copy also, this is how it looks. Okay, this is how the wheel rotates. So you need to turn the wheel and see. So all the 6 parameters will be present there. You will be turning the wheel to find out if this parameter is there with the patient wound. Yes. So this is present, this is present, this is present. One by one, you will be checking by turning the wheel. It's like a small paper like this so that we have. Sorry that we don't have just one thing to show with you also. But it's possible maybe Janaki has got the English show, otherwise they will show it.
Next week itself, I'll plan certificate next year.
Okay. So you need to turn and see. There are 6 parameters which is given on the what to say indicator parameter side. The green color indicator parameters. So all these are indicator parameters. The red ones are direct parameters. So you know the difference between indicator and direct, right? Directly you see first, then it is infected. You don't have to think about what is the manifestation this wound should have for infection. Indicator parameters are manifestations of infection. The usual thing, what is erythema, yes, and heat, warmth on the surrounding skin. So all those manifestations. Okay. So indicator parameters they have given 6 here. If you see 5 out of 6 to be present, go for an antimicrobial local treatment. Got it? So the wound is treated with some neutral dressing, and suddenly you feel the wound is infected. Just pick up your telescope tool and find out if all these are present with my patient's wound. 6 of them are there, and you're finding 5 out of 6 indicator parameters. Immediately switch the dressing to an antimicrobial dressing. Okay. And otherwise, just leave it off. Just forget this green color now. Move on to the red one. 3 parameters are there. I'll explain all this now. 3 parameters are there. Just 1 out of them, which are direct parameters. 3 parameters are direct parameters. There you find just 1 out of them, then it is infected. Here, that's it. Then change, start antimicrobial local treatment for the wound of your patient. Clear, all of you? So clinical signs. What all has been given there? 1, 2, 3, 4. Erythema to the surrounding skin, heat, edema, that is induration or swelling, spontaneous pain or pressure pain, and stalled wound healing, increase and change of the color or smell of the exudate. If you find 5 out of all these 6, you have to be very sure the wound is infected. Clear? Then you will start antimicrobial local treatment for the wound. Okay, erythema, redness of the skin or mucous membranes caused by increased blood flow, that is hyperemia. Do you see this in infection? Yes or no? Yes. Okay. So signs of raised temperature on wound bed or in peri-wound area, heat. Yes, edema, induration. Edema is swelling that is caused by too much of fluid trapped in the body's tissues. Induration is a deep thickening of the skin that can result from edema, inflammation, or infiltration. So edema. So edema is a very common thing. I'm just running on all these points because there is nothing to discuss on all these. They're all very self-explanatory. Okay, pain due to the wound. Stalling of the wound. Okay, stalled wound healing process. In which phase of the wound healing process the wounds will be stalled if there is infection? Beautiful. When there is infection in inflammatory phase, you always see the wounds to be stalled. Even when there is granulation, suddenly infection can reoccur. Then you need to switch your neutral dressing or accelerated wound healing dressing and then move on to your antimicrobial treatment plan. Okay. Exudate, increased volume, change of color, or increased smell of exudate. If you see 5 points out of all these 3, what you will do? You will make sure there is infection and you will go for antimicrobial treatment. Local infection, very, very good. There is nothing connected to systemic infection. Systemic infection is needed or not needed will be definitely decided according to the patient's response to the treatment. Okay, that will be decided on the consultant side. Clinical signs. 3. These are direct parameters. Okay, presence of wound pathogens. How that will be seen? You will see pus. You will see biofilm, the slimy appearance. Yes, foul smelling exudate all together. Whatever we have seen here and there, all together you will be seeing like there is pus. Presence of pathogens is present. Okay, when it comes to surgical wound, what you will expect there to call the wound infected? When it comes to it, beautiful wound gaping. What it is called as? Wound gaping. Scientifically, how do you call it in medical terms? Wound dehiscence. Yes. Okay. So sutured wound edges look edematous and erythematous, wound dehiscence, massive oozing or pus from the sutured side. No question at all. It is breaking and then it is infected. That's it. Just one sign is enough. When you come to direct parameters, just one sign is enough. Then you will move on for your antimicrobial treatment. Clear? Presence of free pus. So presence of pathogens, already you have seen, like there is biofilm and there is foul smelling exudate, necrotic tissue. All these you are seeing on the wound bed. When all these are present, finally what should be there? Pus should be there. Yes, so pus will also finally come out. And you are not seeing anything else. When you're opening the dressing, you are seeing a free pus draining from that. Will you really check for all other signs to confirm your infection? So that is why this parameter is called to be direct indicator. Okay, I mean direct parameter, not an indicative sign. Okay, so direct parameter you call it because there is pus, and already after all those only pus is coming out. Now it is clearly infected. So 1 out of these 3 and 5 out of those 6 that we discussed in the previous slide. If you find any of these, then you'll go for antimicrobial local treatment. Clear, all of you guys? Yes? Clear? Yes. Okay. So find out what local treatment to apply on the back. So you need something to treat the infection, treat the biofilm, and every time the dressing is changed, you want something to do complete and continuous cleaning action. And we have really got dressings which has got all these actions, and you will be finding it. Yes? Okay. Now to talk a bit on biofilm. Now tell me what is a biofilm. Anyways, we already had some definition, introduction about biofilm. What is a biofilm? This is the summary of the release corridor. Can be that. Polymer. I protect myself with more dressing acts on myself. Biofilm is formed. That is why they are all subject components. This one. Style microbes is otherwise called to be biofilm. You will not be able to move. Okay. So assemblage of microbial cells that is irreversibly associated. It won't be reversible. It won't be cleaned easily. It won't be removed easily with your local antimicrobial treatment at all, because it has become irreversible now. It has a protective layer over it. Okay, so that is where you call biofilm. Okay, so structured community of microorganisms. It could be bacteria, it could be yeast, it could be fungi enclosed in an extracellular polymeric matrix, which is very much adhered to the surface. So how biofilms then will be cleaned? Okay, that is where exactly surgical debridement is helping. And not always surgical debridement can be regularly done to remove the biofilm. We need some support also from the dressings. A dressing which is having a polyacrylate fiber will really help in mechanically breaking the biofilm. So which dressing has got that fiber would be really useful for this extra support that is given along with the debridement to remove the biofilm from the wound bed. Okay. So EPS matrix represents 80% of the biofilm, and what the remaining 20% would be. Trapped organic molecules, inorganic molecules, extracellular polymers. Yes. So the microbes will be 80%, and the remaining, all the water content, the organic molecules, inorganic molecules, yes, extracellular polymers, all these will be 20%. So this is how the biofilm is developed in each of the wound, and this is how it is projecting itself to be present on the wound bed. Okay, so look at the cycle. As I have been talking about this planktonic attachment, microbes are there, it's freely moving. Now, when you debride or when you put any dressing, easily this can be removed also sometimes because it is planktonic in nature now. And then irreversible attachment. Now, slowly in the second stage, it started developing some EPS and then grouping and all that, calling the friends for help and forming a protective cover onto it. And then cell proliferation. Very nicely, like the grouping is becoming bigger and bigger. A lot of multiplication is taking place. Growth and maturation. Can you see a layer on it? Yes, over the microbes. So that is nothing but the EPS, extracellular polymeric substance. And after that, it matures too much, and then again it breaks and releases a microbe. It will go there, form colonies. Again, the whole phase will be continuing and continuing. What does it mean? A very firm, very adherent and stubborn biofilm is developed on the wound bed, which will be very, very difficult to remove, manage, and heal the wound. Clear, all of you? So by understanding biofilm and managing biofilm is very important. These days it is not about managing infection at all. I hope even doctors agree to it. These days, it is not about managing just infection. These days, it is about managing biofilm, managing recurrence of biofilm. Just one time managing biofilm is not enough again. The recurrence of biofilm, managing the recurrence of biofilm is important. Okay, what is new that we would like to know about biofilm? Most chronic wounds are characterized by polymicrobial biofilm. 60% of the chronic wounds are having biofilms, compared to acute wounds, where we see only 6% of the acute wounds have biofilm. Clear, all of you? Yes. Now see, like, what is the vulnerability these chronic wounds have in developing biofilm and infection? Yes. So this is a very latest information that we got from one of the PubMed articles. So 60% of the chronic wounds definitely have biofilm, whereas only 6% of the chronic wounds have biofilm. Okay. And ill effects of biofilm, we have been already talking about it. Anchors the bacteria to the wound surface. Is it harmful or not? Yes. So it won't move at all from the wound bed. Protects bacteria from external threats. Yes, we talked about it. Limits the penetration of antimicrobial agents, antibodies, and macrophages in the biofilm. Yes, it will limit. Now nothing will penetrate into it because it has developed a very good cover over it, cover over the microbes. Yes. Delays wound healing by acting as a physical barrier to epithelialization. Yes, you agree with this point as well? Okay. Stimulates inflammation, which increases vascular permeability and production of wound exudate and the buildup of fibrin slough. See, biofilm is there. Again, you're going to see slough. You're going to see exudate. So when that is managed, within some time, again, biofilm is going to develop. So basically, biofilm has to be broken and removed from the wound bed, which is very, very important. Okay, that is done through debridement, and also it is done through the dressings which I have been talking about, which has polyacrylate fibers into it. So International Institute of Wound Infection, IIWI guidelines. Have you come across this? IIWI. Please note it down. Maybe you can check about it later. Morning, I have been talking about one guidelines. What is it? Nice. Okay. What is that? IWGDF. IWGDF. Very good. Thanks for remembering. So IWGDF guidelines, and then now IIWI, International Institute for Wound Infection. Okay. So that guidelines is saying that a dressing which has got polyacrylate fibers will be very, very helpful in removing the biofilm, slough, and all the components which are responsible in forming infection. Okay. How quickly do biofilms form? So this is where exactly I've been talking about. So within minutes, planktonic bacteria attach. Okay. And then within 2 to 4 hours, it strongly make colonies. Okay. They strongly make colonies. And within 6 to 12 hours, they develop initial extracellular polymeric substance and become increasingly tolerant. Okay. And 2 to 4 days, evolve into a very mature biofilm, which I showed the last picture. It will evolve into a very mature biofilm, and then it will be extremely resistant to the biocides, and it will shed the planktonic bacteria. When it sheds planktonic bacteria, again, what does the planktonic bacteria do? It will go and form another biofilm. Yes. So biofilm, finally, look at the last point. Biofilm is capable of redeveloping or reforming within 24 hours. So is it possible to do debridement for highly infected wound every day for a patient? No. So that is why with lot of innovation, dressings have come that they have polyacrylate, polyabsorbent or polyacrylate fibers to break the biofilm and help the doctors in debriding the wound bed, which has got too much of infection and fluff. Clear, all of you? Yes. So clinical indicators of biofilm. Now I really need answers from you all. Okay. So clinically, when you are seeing, have you all really seen biofilm in a wound bed? Now, after understanding all this, really you are able to relate or connect with some wound that you have come across which has got biofilm. What are the clinical signs could be? Clinically. Yeah, could be. Maybe all these are visual signs. Clinically. Clinically, what are the signs do you see on the wound bed or see with the patient? See with the body's reaction to the patient. Yeah, that will be there with infection. Infection itself. Infection is maturing and forming a stubborn biofilm. Okay. So, what do you see on the excessive moisture? Too much of moisture will be there because what is there? It's, yeah, not only infection. Now the infection has matured and developed a biofilm. Yes or no? So there will be too much of moisture. Poor quality granulation tissue. Every time you remove the dressing or clean it, it bleeds and it will hypergranulate. It seems like it is healing, but then actually the wound is deteriorating. You understand? This poor quality granulation tissue would be there. Antibiotic failure or recurring infection, antibiotic cessation. You are putting so much on the wound bed, and bodily also maybe sometimes systemic antibiotics were given, but sometimes there is no reaction to all these antibodies. Wound side, we are not seeing any reaction at all. Why? Because the biofilm is so stubborn. So these are the clinical indicators that we usually come across whenever there is biofilm. Okay. The hallmark of biofilm infection is what? Antibiotic failure. You put something for it and it doesn't work at all, because that is the hallmark of what to say, biofilm infection. Okay. Negative wound culture. You take a swab culture and you send it. There is no growth, but still the wound is not healing. Okay, still the wound looks very infected and it is not healing. Why? Because when we are taking the swab, very free floating planktonic bacteria will be taken in the swab. Most of the time that is captured in the swab. Okay. So the biofilm, which is very, very sessile and very much adherent to the wound bed, will not be taken in the swab. So nicely, it shows negative culture and then the wound doesn't heal also. So it is very critical. Okay. So infection that is lasting more than 30 days. For 28 days or 30 days, you are giving silver treatment. Locally, silver dressing has been used. There is no improvement at all. Then definitely the wound has got biofilm. The matured biofilm is there. Okay. Gelatinous material easily removed from the wound surface. Something slimy sometimes will be removed from the wound bed. When you're cleaning, something slimy is sticking to your gauze swab and coming out. Yes. So all these are the clinical signs. What are the visual signs? As you guys already said, slimy gel-like substance will be seen on the dressing when the dressing is removed. So under the dressing, you will see that. And on the wound site itself, tiny translucent substance on the surface of the wound may be indicative of thin but observable biofilm. You will see on the wound surface, you will see on the dressing. These are the two visual indicators and nothing other than that. All others are clinically you have to see, and sometimes you need to take a deep tissue culture and send it and find out as well, because swab doesn't work. Got it, all of you? Okay. So what is that? Did you know this fact? Okay. The most encountered bacteria in chronic wound biofilms are the escape pathogens. Okay. Escape pathogens. For you to remember, it is given mnemonically here. Escape pathogens. Enterococcus faecium, Staphylococcus aureus, Klebsiella pneumonia, Acinetobacter baumannii, Pseudomonas aeruginosa, and Enterobacter species. Any Enterobacter species. If all these are present, ESKAPE, mostly these escape pathogens are the main villains in developing a what? Biofilm. Don't say samosa. Okay, developing a biofilm. Okay, so the main most encountered bacteria and chronic wound biofilms are the escape pathogens. Clear, all of you? Done with biofilm topic? We'll move on to the next one. Are you all thorough with biofilm now? Yes. Come up with questions as well at the end. If you guys have to discuss something, we will tell you whatever we know. Otherwise, we will come back with a lot of research points as well. Okay. Okay. So to conclude and make you remember and get you reminded of what is biofilm, waterfalls. Constant flow is there, and because of which a slimy green color substance is always developed on the rocks. Yes or no? Yes, it is formed. And why the water is not able to flush it out? There is a constant flow, no? It can flush it out, right? It won't, because biofilms cannot be broken so easily. You understand? So this is one example that you can remember. The same thing happens with your wound bed as well. When the exudate is too much, when the biofilm is there, the exudate is going to be too much. You will put a nice foam dressing on it and you will absorb the exudate. Does it break biofilm? No. After water is flowing, you are putting sponge, you are giving a sponge there and removing the water from there. But we want the water flow to stop itself. You understand? So we should stop the tap instead of using sponge to clean the water. You understand? So this is the story. Maybe I can relate it with biofilm or breaking the biofilm or subsiding the infection. Okay, so no point in just using the sponge to soak the water. You need to close the tap to stop the exudate. So what do you need to do when you're stopping the exudate? So what do you need to do? Otherwise, with this water flow, all those biofilms would be washed out, right? So it's not happening because they are very stubborn. So you want 3 actions. You need 3 actions. When you're choosing any local dressing, according to IIWI guidelines, you're choosing any dressing, you need all these 3 actions. Antimicrobial, antibiofilm, yes. So, and complete and continuous cleaning action. All these have to be there. So it is not only antimicrobial anymore, it is also antibiofilm that you need to go for. And we definitely have a product with great innovation that we found out, which is Urgo Clean AG. Anyways, today's session, we are not going to talk about the products. And this is for your understanding. Later, you can know about the dressing, and we will also help you understand more about the dressing. Okay. So with this innovation only, we came out that yes, antimicrobial is not just needed. So we need antibiofilm because everyday patient cannot go for Zipmet. Clear? You want me to keep this slide for some time or I can move? Okay. So slough, moving on to slough. So do you think slough is good? No. But is slough normal? It's very normal. It's not good, but it is very normal. Without slough, you cannot see any wound crossing the inflammatory phase at all. Okay. So it is the byproduct of inflammatory phase. If you ask me, biologically, slough is a byproduct of inflammatory phase. If a wound is undergoing inflammatory phase, slough should be present. That's why I'm saying all the time slough doesn't need to be present as big dead tissue. It can be mucus, it can be strings. Yes. So the byproduct of inflammatory process is what? Slough. And it is very, very normal for any wound to have it. Do not consider it won't be there at all. It will be there. Okay. But it is not good. Slough will always harbor infection. Slough will always allow the microbes to harbor there and form biofilm. So slough has to be removed. So sometimes debridement will not be so helpful with removing the slough because slough will be very much attached to the normal tissue. So whenever we do debridement and tend to do a debridement of slough, what happens? We also remove the normal tissue. So morning we have been talking about viable tissue, non-viable tissue. Most of the time in debridement, even though it is very good, we tend to remove some viable tissue as well. So that is how debridement works. Okay. So when there is a necrotic tissue, yes, it is very easy. We can find the necrotic tissue, cut it off, and then all the other wound debris can be removed, and we can see like until which depth the wound has been, the tissue has been damaged. Okay. But then when there is slough, we need to be very critical. It is always stuck to the granulation. Okay. The viable tissue. So we should be very careful. So this is all about slough. I'm not going deep into it and it's not required as so. Now tell me, What's the difference between slough and necrotic tissue? Always this dead tissue and slough tissue. So there is a slough tissue debris, dead tissue, necrotic tissue. Okay. So what is the difference between these two? And do you think there is a difference? Yes. So normal. Yeah. You say it's difference I'm asking. What do you say? It's very normal. Slough is very normal, and necrotic tissue, yes, it's not normal. Okay, but any other points to highlight? Slough is different from necrotic tissue. Cannot be reversed. Byproduct. Necrotic. By the slough is the process. Consequence of wound healing process is slough. Consequence of the disease or injury or unrelieved pressure is what? Necrotic. A thick necrotic tissue that is tightly plugged to the wound bed, which is called as that. Cancer. You can all clap hands. Now only you ate samosa, no? Okay. So a thick. Thanks for that extra class. Okay. A thick necrotic tissue that is plugged tightly to the wound bed is called as eschar. You see it with, for example, sorry? Yes, burns patients we see eschar. We see pseudo eschar also because they are apply so much on the wound bed and make it to see as eschar, right? And then calcaneal pressure also. Calcaneal pressure also cannot be with eschar only most of the time. You all agree with this? Because it's a bony prominence. Soon after second stage, third stage, and fourth stage, you can see an eschar developed, and you will not be able to see the stage now. Clear? So eschar will be there. So this is a consequence of wound healing process, and necrotic tissue is the consequence of disease, some abnormality, no blood flow. Yes. So ischemia. Fine. And yes, we'll go to the last point directly. Adherent, viscous, slimy, and stringy, which I've been talking about. Most of the time, slough is present in the exudate. Slough is present, which we are not able to see also. Yes. And necrotic tissue would be very dry, thick, leathery. It is firmly attached, and every time mechanically, surgically, it has to be removed from the wound bed. Okay. Yes, exudate, you all know it very well. How exudate is developed quickly? Yes, of course. Whenever there is an inflammatory process, exudate is also a normal process. Only when it is more in number, then there is a problem. Yes or no? I mean, the amount of the exudate is much. Much of the exudate is a problem. Otherwise, exudate is very, very normal. And one thing, like slough, unlike slough, exudate is very good also. Yes, exudate is very good. Not always it is bad. We need exudate for moisture balance. We have started the topic from there on. So exudate is needed. So it carries the enzymes, it carries the growth factors which are responsible, and it carries the components of extracellular matrix ECM which are responsible for wound healing process. So we need exudate, but not in an excess amount. Clear? When it is excess in amount, then it is not a good sign. That is one of the points that we have seen in which score? Tilly score. Thanks for that. Okay. That is one of the points we have seen in Tilly score. So this is exudate. Anyway, there is inflammatory process. Anyway, there is a wound when it is undergoing inflammatory process. As a response to inflammatory process, the blood capillaries have to ooze out serous fluid, and that is very normal. Okay. So how much it is oozing out and how much it is reabsorbing. And when there is too much, then what happens? That is the problem here. That is the problem, main problem here. And how we need to manage is what we need to be considerate about. And yes, exudate is good when it provides a moist wound environment. It enables the diffusion of immune mediators, I'm just running through because we have been talking about all these points, right? Acting as a medium for migration of tissue repairing cells across the wound bed. It supplies essential nutrients for the cell metabolism and it promotes the separation of dead and damaged tissue. Didn't I tell you about autolytic debridement? Yes. For it, exudate is required. So what are the bad effects when they are more, when it is more in number? Automatically, all the components which are not required for the wound management will also be more in number. Yes, that is why excess of exudate is there. Or when the exudate is excess, automatically the other components which are not likely to be present in the wound bed also will become higher in number. Okay, the wounds are not healing because it slows down cell proliferation. It interferes with growth factor availability. And very importantly, it contains elevated level of inflammatory mediators and activated MMPs. What is the full form of MMPs? Beautiful. Matrix metalloproteinases. The increased proteolytic activity of chronic wound exudate is implicated in prolonging wounds, damaging the wound bed, degrading the extracellular matrix. We need extracellular matrix to degrade and deposit. What it is not depositing and only degrading is happening. Then the wound bed is not progressing. It is deteriorating. You understand? Understood all of you? Yes. When the exudate is more in number, automatically it will degrade the extracellular matrix more than expected than where it should actually deposit the extracellular matrix. And it causes peri-wound skin maceration. We also saw maceration. Okay, wound exudate. So how to really measure this and how to really put it into your assessment? So automatically in your assessment, what to say? Many times you need to, you feel like entering a lot of important things about wound assessment and we end up writing the wound is cleaned with saline and change the dressing. Yes or no? We always feel that we need to write a lot about that wound, but then we don't do. We orally sometimes communicate to the next staff, or sometimes we think, okay, the next dressing is changed, staff themselves will see. Okay, we will have so many things to write about the wound, but we will not write at all. Most of the times we miss to do it. Clean the wound with saline and cover the wound with so-and-so dressing. That's it. So no, not like that. We, at least from now on, we will have some practice of documenting it in a better way. You all know very well in healthcare, documentation is everything. Everything is all about documentation. And in nursing, I'm very sure all the nursing officers and superintendents here would also support this point. If there is no documentation, nurse is caught. That's it. Game over. Yes or no? So documentation is very, very important. So same applies for wound management as well. Wound dressing is done. So please try to put some information about the wound. The basic information what your next staff wants to know about the wound. Because in her period, maybe she doesn't remove the dressing. So what she knows about the wound. So let her also know about it so that if anything is abnormal, she'll be able to really see. Okay, the previous nurse has written that could be question mark biofilm. So query biofilm. Maybe she feels that there is biofilm. Okay, maybe I need to be a little careful if the patient is developing fever. Yes or no? Yes, is it important or not? Very important. Okay, so this is already there. That's why I have put a tag that this is not new. For years together, this exudate thing is there, but nobody is following it. So at least we will try to follow. Just one in a ward, one in an ICU will follow, and then automatically the others will also, like people who are here, go back and follow so that your other staff also will start following it. Okay. So red side is a danger side. Okay. And yellow side manageable. Medium risk is there. Green side, there is no much of risk. Clear? So that is how this actually works. The exudate continuum. This scoring system is called to be exudate continuum. Aids in assessing both viscosity and volume of the exudate. Any score in the green zone should be seen as advantageous to the wound bed. No much of thick exudate, no more of exudate. Everything is normal. So this wound can be normal. So we need not worry about it. Wounds that are assessed as being in the amber zone. Amber in the sense that yellow zone. Okay. Require careful consideration as this category could either indicate an improvement or deterioration. Anytime it could progress, anytime it could deteriorate. So little bit of viscosity and little bit of volume, excess volume is there, more than expected. So I have to be vigilant about it. Green, any score in the red zone should be investigated urgently as this may indicate local or spreading infection. Spreading infection, imagine we are putting the patient's life to danger because we are not passing this information of patient has got thick exudate to the next person. Okay, so if it is at least passed, when there is a slight fever, the nurse will be able to connect it with the wound. Yes or no? Yes or no? Do you all agree with this point? Yes. And you all know that I'm a registered nurse? Yes. I'm a registered nurse and a midwife. And after that only I've done my executive MBA, and lot of time I have spent in clinicals also. And I was a tissue viability nurse specialist working in clinic, working in Global Hospital Chennai for 2 years. And then I've started teaching about tissue viability to many nurses. And then I moved into marketing and then become a brand manager, and then now mix clinical and branding together, medical affairs I'm doing. So why I'm suddenly bringing this point is it was tough for me to follow all these as well, but then I followed. So I'm very proudly saying that I followed all these. After knowing that wound management is important, after becoming a viability nurse manager, I really followed all these. Whatever I have come across, I never failed to ignore at all. I followed and it really helped. Okay, so it will help you all as well. So you can put the scoring in this way. 5 for volume, 5 for viscosity. Then it becomes 10. Okay. So exudate continuum. Patient is on 10 score. It is understood by the next staff automatically. You don't have to, you cannot put this color coding and all, of course. So you will do that. And if you're able to imprint this and put it in your wound assessment form, well and good, you can tick it and other nurses see it. But when you're writing in the nursing progress notes, you can write in this way. So it is a 9 score or 10 score. Imagine for a patient, viscosity is medium. Okay. And then volume is high. How much is the score? 8. So if you put 8, automatically it is understood that, okay, one side, I mean, either volume or viscosity is little low, medium, and the other parameter is very high. Okay, then amber automatically 1 and 1. It becomes only 2. Okay, 2 scores. So this 5, 3, 1 can be followed. Otherwise, simply you can at least write in this way. This patient's exudate is falling on the red zone. Then everything is in danger. Understood clearly. Yellow zone, medium. Viscosity is medium, volume is medium. Okay, exudate, there is exudate. Clean the wound dressing and changed and everything automatically, like whatever you write, you will be writing. And after that, exudate is in green zone. It means exudate is not a problem to that patient. At least let the next staff understand that exudate is not a problem. You understand, all of you? Okay, try following this and see like how it works. Okay, color of the exudate, you all know. The very normal exudate colors only I'll show you from here. Pink and red is okay. And then the first one, pink, light pink, clear, light pink, all this is okay because all those are sanguineous drainage where normally any wound exudate should have. And sometimes this clear amber is also normal, but sometimes very rarely some infection could be there. Dark red, always we feel dark red is only traumatic to the wound bed. That is also there. When you're forcefully removing a gauze dressing, there is a dark red exudate. Of course, it's a blood that is coming out. With very strong infection, also sometimes it bleeds. Abnormally, the wound bleeds. Okay. And when there is a green, gray, yellow, green color, you all know Pseudomonas infection. Gray color, any gram negative bacteria could have this dark yellow color, brown color, gray color. All these exudate are not normal. Maybe the first one, slightly the second one, and completely the last one. I mean, last one in the sense, fourth one. So all these could be a normal exudate color. So if you see anything different, always please make the primary consultant of the doctor knows that the color of the exudate is very abnormal to the patient. Okay, most of the time we change the dressings and don't communicate about this exudate color or anything. It might give some problems to your patient. So anything that you find out, always try to communicate. Got it, all of you, about exudate? Yes. Odor. Do we really have any scoring system or tool or anything to identify if the exudate is or if the wound is really having a bad smell? Yes. And sometimes odor plays a role or not. When there is too much of infection, of course the odor is going to be there. Yes or no? Or for many underlying factors, the odor is going to be there. Just a practical assessment. And I have given a reference also below. So just a practical assessment. We don't have any other go with odor at all. So any idea? What is the practical assessment? Yeah. Very strong pungent smell. Yes. Burns. That is one, what to say, very typical smell that we always see from burn wounds. Yes. So no odor. At the bedside, dressing is completely removed, wound is exposed, there is no odor. Then you monitor, then you write down, there is no odor on the wound bed. There is no odor from the wound. Yes. Slight malodor. Odor evident at close proximity to the patient when the dressing is removed. Dressing is removed for the patient here. I'm standing here. There is smell coming out. So then is slight malodor. Got it? Moderate malodor. Odor evident on entering the room when dressing is removed. Dressing is removed in the OPD and your supervisor enters into the room and says like how bad it is smelling. Yes. Then the odor is really, really moderate. It's not slight anymore. Strong malodor. Odor evident on entering the room with dressing intact. Dressing is not opened at all, but it smells like anything when the patient enters the OPD. Yes or no? Have you seen all this? Very much. Yes. So this is how we can always say strong malodor has been assessed. And please write it down. Documentation. No more cleaning the wound and putting the dressing documentation. Okay. Okay, all of you. Okay, now it is very clear, I think. The wound healing continuum. Black necrotic tissue, slough tissue. It is becoming granulated red in color and then epithelialization pink in color. You know the continuum now of the wound healing process? Yes, very good. Wound infection continuum, spreading infection, localized infection, critically colonized, and then colonized. You know the difference now? Yes or no? The continuum of infection. Okay. Wound exudate continuum. The critical one is red. The moderate one is amber. And then the green one. So I think it's very clear now to all of you. Since we have been discussing on a lot of phases and all that, I don't want you all to confuse. That's why I have put a recap here. You all understood it now? Do you think all this is useful? Yes or no? Yes. Okay. And yes, biofilm, infection, all this is always a vicious cycle. There is biofilm, there is infection, increased exudate microbes. Microbes are there, again biofilm forms, again wound debris will be there, again increased exudate. Increased exudate is there, microbes will form and then again biofilm will develop. So you cannot break it at all. It's a vicious cycle. And in order to break the vicious cycle, as I have already said, combat the bacteria, combat the biofilm, cleanse and remove the wound debris. So find a dressing for that along with your debridement, what surgeons are doing, find a dressing for that problem, particularly when a patient is having biofilm, and then treat the wound of the patient. Okay. So this is what makes the exudate reduce quickly, and treating the cause of exudate is more important than absorbing the exudate. Yes or no? Absorbing the exudate will go on continuously. Every day you will absorb. But treat the cause of the exudate. Stop the formation of the exudate. Clear all of you? Yes? Okay now. These ulcers are red, healthy, granulated ulcers. Yes or no? Yes? This is how it looks. Have you all seen it? Yes? Okay. What is this? What is so visible on this? Okay then. Slough. Too much of slough. What is this? Necrotic tissue. Eschar. At least someone, it is eschar. I mean, it is necrotic tissue, no doubt about it. At least she came up with the point eschar again, just to remind. Okay. Eschar necrotic tissue. Fine. What is this? So highly exuding and infected. There is also biofilm. This is very easy again, no chocolate. Okay. And what is this? Somebody said epithelialization. Epithelialization. Yes. Are you able to see epithelialization there? After granulation, you see epithelialization. So in two ways, epithelialization will occur. Venu was also saying. So what are they? From the edges. From the hair follicle. So always you can remember this thing. From the edges, it will migrate. And on the wound bed, you can see islands of epithelialization developing. So there are a lot of droplets. And when you connect, it will become a big drop when you put water droplets on the floor or table. Yes. Same like that, epithelialization also works. Here and there as islands and patches, epithelialization will be there. And all those will merge and form the epithelialization cover for the wound bed when the wound is contracting. Okay. Yes. Thank you. Fine. This is epithelialization. And what do you see there? Yes. Again, she said. So already you got one chocolate. So maybe who said overhydration? Okay. So overhydration, which has caused the surrounding tissue to macerate. Okay, macerate. So this is maceration of the surrounding tissue, which will make the wound bed very, very fragile. Figure also. Okay. Blister in the surrounding skin. Very, very simple. Yes or no? Sometimes after the surgical, any surgical procedure, with the betadine and with the dressing that we apply, is after when we remove, blisters will be developing on the surrounding skin, or sometimes due to an infection or too much of friction and force on the surrounding tissue, these blisters will develop. These are all the assessment points. When you are assessing the wound bed, when you find all these, I want you to write down all these in your nursing notes. Okay, that's why I'm showing you all this. And what is this? Diabetic foot ulcer. And what is on the surrounding skin? What wound is it's a diabetic foot ulcer. What typical sign that you see of this diabetic foot ulcer? The surrounding tissue, how the surrounding tissue looks. Yeah, it is dry. Why it is dry? Oh, I won't say necrotizing and all, definitely. Doctor is giving clue also. Okay, maybe I'll tell you this. Hyperkeratinized. The tissue is hyperkeratinized. What it is? Callus, of course, it's a callus. Diabetes, no chocolate. Maybe to doctor later I'll give. Okay. Yeah. He said CALLUS also. After that also you all didn't say. Okay, hyperkeratinized. So callus. So always callus is a very, very critical diabetic foot ulcer. So under callus, nicely the wound will be progressing and deteriorating and deteriorating, and we will not know. We will think that the wound is healing. Yes, have you all experienced this? That is how the diabetic patients also do. They'll think, okay, the callus is there, okay, the wound is healing. Actually, it healed 2 weeks ago, ma'am. Again, it is redeveloping. Why that is happening? Because the callus is building inside. The wound is not healing. The callus is always a very critical one to assess. Okay, erythema of the surrounding tissue. So it could be possibly, mostly by infection, possibly by any other dressing that we use, and the toxic substances, toxic fluid. Yes. Okay, edema of the surrounding tissue. You see this in cellulitis. Yes, you see this edema. Most of the time, edema you see in venous leg ulcers. Yes, and cavity in the wound bed. You all know what is cavity? The depth is too much. Yes, so that is what you call as cavity. And yes, so one question: how do you measure the wound bed? Length, width into depth. Yes or no? So leave about depth. Not all wounds are going to have depth. Length into width. So which side, which one is length and which one is breadth? Breadth or width? Width and breadth are same. Okay. Length and breadth. So how length is measured? How breadth is measured? The scale, of course. Very good, very good. So always the longest side is not length. The longest size is not length. Okay. If I have a wound here and from this to this, from side to side measurement is 6 for me. Okay. And this is 4 for me. So don't write 6 into 4. That is ulta. Write 4 into 6. What comes first is length. Okay. And what is measured head to toe is length. Head to toe direction is length. So whatever is lengthier, you shouldn't write it as length. So that kind of mistakes also is happening with wound measurement. So head to toe is length, side to side is breadth. And if there is depth, you will put the swab stick inside, which is a very traditional practice. Put your swab stick inside, pinch, take it out, and then measure with a scale. That's it. Okay. So what is this? Typical depth only, cavity only, but then something typical about this depth or this cavity. What is it? Sinus tract in the wound bed. Yes, there is an entry and it goes somewhere and hits. It could hit bone, it could hit tendon, it could hit muscle, any layer. But there is a sinus tract, an abnormal fistula, an abnormal opening that is there. Okay. So what is this? Something like fistula or sinus tract only, but a typical name is there given for this one because there is something different. Beautiful. Okay. Tunneling. Tunneling. Why tunneling? Clap hands. Why tunneling? There is entry and exit. So imagine yourself traveling in a train. You enter the tunnel and then you come out. You're not going to continuously travel in the tunnel. You go inside and you come out. So remember that so that you will not get confused. Okay. So there is entry and exit is tunneling. There is only entry, then it is sinus. But most of the time, both these are called to be sinus. Okay. But then a slight differentiation between these two are you have entry and exit, then it is tunneling. Only entry, then it is sinus tract. Okay. Okay. What is this? You are able to see something? Two wounds I have given there. No, doctor is leaking it out. Who said you? You copied from him only, no? Then no chocolate. No chocolate. Just kidding. Okay. So undermining a space between the wound bed and wound edge. Or you can say when the wound edge is detached from the wound bed, you call it as undermining. So a lot of pocket formation, lot of curling of the edge and not epithelial cells are really not forming properly and migrating because the wound edges are not attached. When the wound edges are not attached to the wound bed and they are detached, you call it undermining. Or another definition you can understand, that is the space between the wound bed and the wound edge. That is called to be undermining. When you're cleaning any pressure injury or diabetic foot ulcer which has got a depth, you're just cleaning the edge of the wound. Suddenly your forceps slips into the side of the edge and then it comes out. Okay, there is undermining. Clear? Okay. So yes, undermining. Why I have put a clock picture everywhere? Oh. So always when you're measuring, insert a clock, insert an imaginary clock into the wound bed. Head to toe is what? 12 and 6. Side to side is 3 and 9. Okay. In this wound, you tell me, where is the undermining present in the first wound? 3 and 4. Yes. From 3 o'clock to 4 o'clock, you can see a mild undermining that is present. Can you write down like this in nurse's notes? Easy or tough? Very easy, no? You look at the wound and you'll know which side there is undermining present. So easily you can write down this patient has got undermining in 3 o'clock and 4 o'clock position. So at least they know like, okay, undermining is there and also how much big it is because they have written 3 o'clock to 4 o'clock. Okay. Size of the wound is 6 into 6. Then undermining is also a little bigger for this patient. You understand? So this is how assessments and documentation should be working. So always put an imaginary clock, tunneling at 4 o'clock position, sinus tract that is present in 9 o'clock position. You understand? So it's very easy. Nobody will come and ask you that where is 9 o'clock means what? Because it is understood. When you all follow the unique practice of inserting the clock, that's why this practice came. Because everyone understands. Because clock works in the same way for everyone in every place. Okay. So you put an imaginary clock into it, 12, 6, 3, 9 automatically. And wherever there is undermining sinus or whichever in the wound bed, put an imaginary clock and write down. Don't try to write slightly upper, slightly lower, slightly side and all that. That's not going to help us. Thanks, doctor, for adding. So put an imaginary clock into every wound, and whatever assessment you find, there is a lot of slough present in the 3 o'clock to 7 o'clock position. So it means automatically we know which wound, this part of the area is covered with slough. Okay. So don't write side, upper, lower. To many people, side is different, upper is different, lower is different, slightly is different, moderate is different. Okay. So write something which is uniquely followed and understood by everyone. Okay, tissue bridging. Have you seen this? Is there tissue bridging that you're able to identify? Yes? This one. Yes? And this one. Yes? Yes or no? And this one. And again here. Yes? Tissue bridging. So there is no complete disruption. When you put an incision on the skin, there won't be tissue bridging because you cut everything off. In which wound do you see this tissue bridging? Example is already there. Laceration. Laceration always will be so irregular. The edges are irregular, and you can't approximate the edges. When you put incision, you can approximate easily and put a suture. Example: surgical incision. Okay. So laceration, a blunt force which has created a skin tear to happen. That is a laceration. Okay. So there a skin tear is happening. Laceration has been identified, and you see some tissue is bridging from this side to the other, which is not cut. It's very difficult to handle. Somehow it will be cut when we are cleaning and all that. Okay. So this is the hallmark identification or the appearance of a laceration. In any book you will find this hallmark appearance of laceration would be tissue bridging. So I want you to understand or know what is tissue bridging. So I have put it here. Okay. And induration and hardening of the tissue. Can you see induration? What is induration? Anyways, I've given answer there only. Hardening of the tissue. When there is too much of infection, like edema and erythema, this is also one of the signs what cells will have, the tissue will have. Hardening of the tissue. Can you see a massive hardening of the tissue here? This is how induration looks like. DFU, arterial leg ulcer. In all these places, we see enormous hardening of the tissue, which is called as induration. So always try to write in your nursing notes when you are handling lower extremities ulcer. Induration within the bracket plus. It means induration present. Try to write it down. So let the other next staff or your treating doctor knows that, okay, this patient has got induration. Then it's a massive cellulitis. Have to immediately start then with antimicrobial. You understand? It's very important. Don't clean the wound and only close the dressing. Okay. Apart from all that, you need to really cover all these points. Demarcation. Where is the demarcation here? That clear black border that has been formed and separation that is between the viable tissue and non-viable tissue. Can you see clear demarcation? So where do you see that demarcation? The second picture. Arterial leg ulcer. Yes, arterial leg ulcer, which has become a clear dry gangrene. Okay, so gangrene of toes, gangrene of forefoot. In all these places, you see clear demarcation. And the first one is crush injury, where the finger was almost off and they were trying to suture it, and there is no vascular support anymore. It is not able to cope up, so it's gone. Okay, so this is one example I have taken. So one acute wound example, one chronic wound example I have taken here for demarcation. So demarcation is mostly a sign of ischemia. Clear? You see ischemia on tissue, then you will find demarcation. Fine. Hemosiderin deposition. What is that? Deposition. I have given a pictures also there. Yes. Iron is trapped. Iron is trapped in the tissue. Where this happens? In which condition of chronic wound it happens? In which condition of chronic wound this happens? Lot of clues, huh? Venous leg ulcer. Venous leg ulcer. Venous leg ulcer. What happens in venous leg ulcer? Blood is pooled. Blood is not able to be taken back to the heart. So it is getting pooled in the tissue. Okay. The opposite is what? Arterial leg ulcer. Blood is not able to be provided to the tissue. So tissue lacks blood and it becomes thin and ischemic. Yes. So that is arterial leg ulcer. Venous leg ulcer, too much of blood is pooled in the extremities without going back. So pooling of blood blood is pooled, what it means, like iron pigments are also trapped. When iron pigments are trapped so much under the tissue, what happens? That blackish discoloration should happen. So that's what is hemosiderin deposition. All venous leg ulcer patients, post venous leg ulcer treated patients and all, you see underneath they'll have this black color discoloration. Okay, so that is hemosiderin deposition of the wound. So you should mention like hemosiderin deposition of the wound or tissue, because hemosiderin deposition happens in other places in our body also. So you should be little clear with that. Okay, and denudation versus excoriation. You know what is excoriation? What is that? Nice action, but I know, but I want to know the definition. But I like the action. Okay. Excoriation is something that is caused on the skin superficially with a mechanical force, like friction with pressure or with anything. The superficial layer of the skin is lost. Okay. So what is denudation? Same happens, same thing only. They say sometimes it is with friction also we call denudation, but mostly when we call there is skin denudation, it is because of the toxic fluid from the body, urine, stool that is stagnated on the wound bed. There is a sacral pressure ulcer, and over the sacral pressure ulcer, peri-wound skin, you always see skin excoriation. That skin excoriation you should call as denudation. You understand a slight difference. Most of the time it is misplaced. Not a problem when it is misplaced, but just for you to know the difference between very much denudation. Okay, very much denudation. So rubbing, scratching with all these, that is excoriation. Loss of epidermis caused by exposure to urine, feces, body fluids, wound exudate, even maceration creating excoriation is also denudation. Okay, but regularly we call it excoriation, but I'm just trying to give you the difference. We all can become advanced also, no? When something is correct, we can start following it. Yes. So you can start writing denudation instead of excoriation in all these places so that others also learn from. Okay, got the difference now? Clear, guys? Yes or no? Okay then. Okay, last question of this session and then over to Venu. So I bring danger when I'm in excess. Wait, let me put one clue. When I am in excess, I am a danger. Who am I? Try to connect with this. Yes, moisture, yes, in a way, yes. But try to connect with this picture. I'm asking about something else. Next picture. Two pictures. What the first picture talks about, what the second picture talks about. Building and breaking down. Yes. So one which is responsible for doing this. But when I'm excess, I'm danger. Connect that also. When dressing is excellent, that itself is a danger or what? Maybe patient will feel discomfort. Final clue, you are not able to understand with this? Such a big clue. No. Beautiful. Okay. Before a doctor could give a clue, I actually prevented it. Okay, he was about to. Okay, matrix metalloproteinases. That equilibrium is lost. Okay, that's why I put this picture. So when they are more in number, I don't know how to really take it. When there are more fishes, I don't know how to eat and which one to eat. Likewise, when they are more in number, I don't know how to really control it. Okay. So matrix metalloproteinases. What is matrix metalloproteinases? Quickly. These are the ones which are helpful in breaking down and building up of ECM. I've been talking about ECM, right? And I also said ECM will always deposit and degenerate. Deposit and degenerate. So for the deposition and degeneration of ECM, you need MMPs. They are good or bad? They are more in number, they are bad. That's why I said. Okay? When I am excess, I am writing. When they are more in number, they are bad. Otherwise, MMPs are very, very important for wound healing process. When I become more, when MMPs will become more. when the infection is too much, and when the infection is capable of keeping the wound in inflammatory phase for a prolonged period of time. So chronic wounds will be automatically more in MMPs. Okay. So they are very, very important for deposition of ECM and degradation of ECM. That's why I showed first two pictures, deposition and degradation. Okay. And yes, it does a beautiful cleaning of the wound bed. MMPs are very important. They do a beautiful cleaning of the wound bed. But when they are more in number, what is it? MMPs, the food for MMPs is non-viable collagen. Okay. Non-viable collagen will be eaten up by MMPs. Remember. Okay. There are like one puppy or one horse has been given food. Other horse has been given food. Other horse has been given food. Something like that. Okay. So when there are more than 3 horses, but the food has been provided for only 3 horses, what they'll do? They'll start snatching food from the other horses also. So if the virulence is too much, that's what happens. So that's the same concept here with MMPs as well. Okay. So the food for MMPs is non-viable collagen. The MMPs are more, what they'll do? They'll start eating viable collagen. They'll start eating viable collagen. Then automatically wound healing process stops. In inflammatory phase itself, it will stall and stall and stall, and it will never progress. So that's what is happening in chronic wound management. How MMPs are first of all developing? Let them be in normal amount. Who is actually triggering them? During the inflammatory phase, the infection which is triggering them. Okay, the bacteria will produce MMPs, and it will also allow the body to produce excess of MMPs, endogenous and exogenous MMPs. All the protease levels will be increased now. And after that, somehow the infection is not able to be controlled for a long time. So MMPs have been improved and improved and improved, increased and increased and increased, and the protease level is like too much now. And after some time, the infection has been subsided very well by systemic antibiotics and antimicrobial dressings and everything. So MMPs also will automatically subside, or they will stay there. Along with infection, MMPs also will subside, or they will stay there. They will stay. They won't subside. Maybe further production of MMPs will be limited because there is no infection. But the infection, the bacterial protease which has developed the body's protease will stay there. That is the problem with chronic wounds. Infection is done, but for 6 months, patients will regularly come for dressing. Yes, because MMPs are more. It will not allow the wound to heal. They are eating up collagen every day, so wound doesn't get collagen to heal the wound. So we need a dressing to accelerate the healing process by reducing the MMPs. Understood? So in chronic wounds, an excess of MMPs is systematically demonstrated, and they will always alter the equilibrium of the wound bed. So MMPs are controlled by TIMS, TIMPS, trans inhibitors of metalloproteinases. MMPs are matrix metalloproteinases. Matrix metalloproteinases are controlled by TIMS. Okay. So when the MMPs are more in number, TIMS will not be able to control the MMPs. Clear? Tissue inhibitors of metalloproteinases. So tissue inhibitors of metalloproteinases will not be able to control the MMPs when the MMPs are more in number. It will go out of the control now. So what will happen? TIMS will go down. TIMS number will go down. Which numbers will be more now? MMPs will be more now. Collagen will go down. Reactive oxygen species will be more. So all the factors which are not supposed to be more will become more, and all the factors which are supposed to be more will become lesser. So now there is clear disequilibrium in the wound environment. Clear or not? Yes, understood all of you. So one MMPs factor will bring all these process of disequilibrium in the wound bed. So reducing MMPs even after the infection subsides is important. So it's not very easy. We don't have a lot of dressings come in the market for reducing the MMPs. Okay, yeah, I'm really forgetting this. So for MMPs, that's why we see why I bring this point is that's why we see a lot of patients coming to us for dressing change for a very long time, like 6 months, 7 months. Also, they come and get the diabetic foot ulcer dressed. Okay, even after the infection subsides, because the MMPs will be still more for them. which will not allow the wound bed to heal at all. Understood, all of you? So imbalance causes delayed healing. It's not always infection. Imbalance causes delayed healing. So with this, I'm just finishing this module, and we have one more module to be done by Venu. Yeah. 5 minutes bio break and last module, doctor.
So we'll start with the session. You're fine. So I'll rush up since madam want to go home early. Okay, fine. Fine. So in single slide, I'm presenting all acute wounds here. Acute wounds. Shall we? Okay, fine. So first acute wound is avulsion wound, which was have the strong shear force. You can see deep cut in this avulsion wound. And next, Gyula has touched upon laceration wound already, where she has shown the bridging of the wound. So most probably you will see when boxer punch the opponent, you may see the breakage of the deeper layers of the skin, and you may see the bridging of that wound, the laceration wound. And next, I am going to the incisive wound, which is a straight scalpel cut. So which is surgically made, or which is surgically the wound is developed with this surgical instrument is called as a incisor wound. So incisor wound and lacerated wound share the same pathology, but lacerated wound have irregular edges, and incisor wound will be having straight cut. Most probably surgical wound will come out incisor. And next is contused wounds. So hemosiderin deposit. Already you have corrected this wounds. Contused wounds means which will happen due to the blunt force or third force. Usually, a simple example what I can give is when you're closing doors, sometimes your top layer of the skin will get caught in between the door and the door edges, and blood clot will be seen here. That is a simple example for the contusion wounds. So it may be bigger in size also due to the blood. And yeah.
So it is like hemosiderin is what he is meaning. Hemosiderin.
This is different. And next is puncture wound, where you will see with the nail pricks or bullet wounds will come under the puncture wound. And last is abrasion, where due to the friction, most probably bite falls or cycle falls will lead to the abrasion wound, where top layer of the skin will be lost. So I hope all these are coming, wrapping all this. Most probably every person will be having this abrasion wound, and dressing change for this abrasion wound will be very painful. You accept this? Yes. Yes. So if I tell you a dressing is there which will cause no pain, will you look for it during the dressing change? For abrasion wounds, during dressing change, you are having lot of pain. Our dressings, which will be shown later. So we have the dressings, if you are applying the dressings with the TLC technology, during the dressing removal, there will be no pain when you are removing the dressing. It has been proven in multiple studies, and it was effective also. Okay. Next is, since lot of people use from burns word, I need to little bit deep diving into the burns. Okay. Yeah. So what does it happen? You can see at home 62% with statistics, and at work 21%, automobile 6, and others is 11% is the incidence. Coming here, what you are seeing in this picture? Rehabilitation after burns. Rehabilitation of the burns is very painful, where people will lose the contraction capacity, and joints will be stiffened. All these problems will be there. So a study which has been conducted on 90 patients, the people have suffered with this type of problems for 17 years after burns injury. So rehabilitation of the burns is a serious component where we need to keep in our mind. Not only healing the burns wound, rehabilitation of the burns also will play a major role in psychologically affecting the patient. So which chart you are using? Rule of 9 or London pronouns? Okay. So these are the assessment charts which we use for the burns. And coming to the type of burns, can you name the type of the burn? now, you are telling electric bonds. Yeah, fine. Based on the layers, based on the depth, what are the? Yeah, fine. Very good. So I'm going to touch on only. So based on 3 layers of the skin, we have 4 different types of bone. When we have effect on the epidermis, it is first degree bone, it is superficial bone, and dermis is divided into the 2 layers. One is superficial and deep. So if superficial layer of the dermis got affected, superficial partial thickness bone, and deep layer got affected, then deep dermal bone. Okay, and coming to the 3rd degree, where you have the full thickness bone until the subcutaneous layer will be called as a 3rd degree bone. So we have 4th degree also. We will not on the topic also coming slide. So leave on the first degree bone. So first degree bone will be healed very soon. So coming to the 2nd degree bone, what is the challenge in the 2nd degree? Pain. Why? Most of the nerve endings have been burst and blister. Will you accept this? Blisters. Okay. So in next slide we have what to do with the blister. Okay. So next is deep 2nd degree bonds. Already we explained it. And 3rd degree bone also already we explained. And coming to the 4th degree bone. So upon these layers of the skin, if the burn injury is extending to the muscle and bone, then it is called as a 4th degree. Clear now? So 4 degrees of burn, 3 degrees we already seen, and 4th degree is when the burn injury has spread to the muscle or bony components, then it is called as a 4th degree. Okay. So now we're clear with the degree of burns. Here, whether to keep the blisters or not. Why we need to keep that blister? Moisture. Okay. Whether it attract infection? Of course, because okay, give me.
அக்கா டாக்டர் அட்டெண்டன்ஸும் நம்ம டாக்டர் அட்டெண்டன்ஸ் கண்டிப்பா எடுத்து கவர் இது பார்த்து கவருக்குள்ள போட்டு விட்டுருங்க. ஈவினிங் நான் நம்ம டாக்டர் அட்டெண்டன்ஸ் லாஸ்ட் மந்த் வருது, இந்த பிரவுன் கவர்ல போட்டு வைங்க. இன்னைக்கு ஈவினிங் நான் வந்து வாங்கிட்டு போயிட்டு நான் நாளைக்கு மார்னிங் இப்படியே கொண்டு வந்துருவேன்.
Yeah. Yeah. Rightly said. Upon the blister, you will see dead skin on it.
ரெடி பண்ணி வைங்க. முடிஞ்சா நம்ம அட்டெண்டன்ஸ் ரெடி பண்ணி வைங்க. அப்படி இல்லாட்டி நாளைக்கு கூட கொடுப்போம்.
Why I am not able to do it?
அதுதான் எவ்வளவு நாள் லீவு, யாரா எவ்வளவு அட்வான்ஸ் வாங்கியிருக்காங்க. எடுத்து வைங்க, வரேன். சரிக்கா.
Okay, fine. Blisters, which is attractive. To remove the blister or not is a big question for most of them. Blisters which are less than 6 mm in diameter may be attacked. The blisters which are more than 6 mm size.
Observation.
Mr. Shiva.
என்ன வாங்கிக்கிறதுனா
So debridement of blister is required when the blister size is more than 6 mm. 6 mm means 1 centimeter is divided into the 10 mm. So approximately more than 6 mm blisters need to be debrided. Okay. So that is the consensus what has been given. Whatever the point we are telling, it is with the evidence which has been quoted on the bottom of the every slide. Okay. So 6 mm less blisters can be kept on intact. And the if the blister size is more than 6 mm, you can break it and you can debride it and you can follow the other treatment modalities. You can remove Eula. So clear with the blister management now? Okay, fine. This is the important point which I thought to nudge on. Yeah. So wound management in burns. So more than me, you may tell me what management you need to do in burns. People from burns. Yeah, you have key points over there. Allow gases exchange, allow high humidity, be compatible with the topical therapeutic agents what you are applying, be non-toxic, non-irritant and non-irritant dressings or ointments, protect the wound from the physical damage and microorganisms, be able to allow maximum activity for the wound to heal without retarding or inhibiting any stages of the process. So as I quoted, what is the most of the collagen is the dressing what you use for the bones, where once you apply, once wound heal only, it automatically peel off or automatically absorbed collagens are also available in the market. So if the wound got infected in bones, what is your treatment practice? Anti debridement. Okay, post debridement, you will debride. What you will do? Again, you will apply collagen or what, madam? Until that, topical anti dressing. Very good answer. Ointments, topical antimicrobial ointments used. Okay, fine. So silver sulfadizing. Okay. So it is contraindicated when wound got infected. It is contraindicated to use silver sulfadizing. We have recent publication on silver sulfadizing ointment. So silver sulfadizing will act on bacteria and infection. For sure, I am accepting this, but it was delaying the wound healing process. Okay, so if you get deep dive into that study, we will understand what is the delay it was happening and how it was causing the delay and all. Okay, so silver sulfadizing ointments should be not used in the infected wound, especially. Okay, so upon that, you can give some antimicrobial dressings which will be not reacting to the wound bed and providing the antimicrobial effect. And one more question is, today you are applying silver sulfadizing ointment. So what is the duration of its action? Till how much time it will act on the wound bed? So you have time that 8 hours, 10 hours, 11 hours, or 12 hours, or 2 days, 3 days like that. 1 day. Okay. Imagine alternate day you are applying. So what is what is the action period of that silver sulfadizing ointment? Please go and check. It will be between 8 hours to 12 hours. After that, it will become food for the microbes. Okay, and one more thing is, today you are applying ointment, silver sulfadizing ointment. Tomorrow, who is cleaning that? Who is cleaning that? You are only cleaning that. So are you damaging any viable tissue during when you are cleaning that ointments? Okay, and you're washing, right? At least with the cotton stuff. So viable tissue also will be minorly get damaged. Possible damage is there. So all these things you can avoid if you find some dressing which will stay for the longer duration with the antimicrobial effect is what I'm trying to. Okay, so fine. We'll go on to the chronic wounds now. So already said venous leg ulcers has been outline has been touched up by the Beulah. So we have three chronic wounds which are leg ulcers, diabetic foot ulcers, and pressure injury. These three only called as a chronic wound. Okay, and the wounds which are acute and staying for the longer duration, they will be called as a long lasting. Okay, not chronic wounds. Okay, these wounds are called as a chronic from day one because ulcer will be developing from inside and opening up. How it will develop from inside and how it will open up, we'll see in the upcoming slides. Okay, leg ulcers. So this is the consensus which has been given in 2019. Average leg ulcers healing time is 2 days. Average leg ulcers healing. Okay.
Despite standard treatment.
Okay, despite standard treatment. Okay. So now we'll understand what is venous leg ulcer. So how veins will function? Veins have valves. What? Yeah, I'll explain. Then you can help me in adding points. Okay. So muscle have valves which will hold on blood when it was pushing blood back to the heart. So here, if you see, heart is pumping blood towards gravity and with some pressure, which is blood is flowing in arteries with the pressure applied by the heart, and the blood flow is towards gravity, which is an add-up advantage for the arteries. But coming to the veins, the pressure will be very less when it was coming return, and it should come in opposite direction to the gravity. Most probably, especially in legs. Okay. So here, a muscle is there which was helping veins to push the blood back to the heart, which is calf muscle. So when you're walking or when you're moving your legs, this calf muscles will contract and relax, which will put a pressure on the veins, and veins will pump blood back to the heart. So now, if you see, when you're sitting for longer duration during your travel, you must feel slight edema, especially in older people, you will see edema a lot. Okay. So why it was happening means your calf muscle is not working for the longer duration. Since you want to travel Manipur through train or some means, you may have edema, right? Okay, fine. So when calf muscle is not working, you will be having edema. Okay. So here calf muscle need to work in a right way to pump the blood back to the heart. When the blood is stagnated or stalled in between the valves, then you will see edema in the patient. Okay. That is venous return. So you can see a nice, why my videos are not playing, I am not. Okay, fine. So here I have a nice animation how veins will close and hold the blood. Okay. So between two vein chambers over there in the picture, when blood is pumping, the valves will hold the blood in the right way. And coming to the next picture, this one is playing. Yeah. Okay. So here you can see when blood has been stalled, it will put more and more pressure on the valves, and valves got diseased, and the distance between the valves will increases, and holding capacity of the valves will also reduce. When this happens, the blood backflow will be blood retention, you can see in the veins. When blood has been stagnated like this, it will put on more and more pressure on the adjacent areas, and blood leakage will be there, capillary leakage will be there, which will lead to the hemosiderin. And this pressure continuously applied on the adjacent muscles. What will happen when pressure exerted continuously on the adjacent muscles? Slowly, due to the pressure, lack of blood supply, followed by ischemia. When lack of blood supply has been continued, it will lead to the necrosis, and then ulcer, and ulcer will open. Now ulcer is developed inside, and then it was opening up in the venous. Okay. Next is arterial leg ulcers. Already Beulah has touched this point also. When arterial blood supply has been stopped to the particular area or particular part, what will happen? Again, necrosis, ischemia, and tissue ischemia and ulcer. Okay, so this is the difference between venous leg ulcer and arterial leg ulcer pathology. So now, mixed arterial and venous leg ulcer. So if you come with the incidence, you can see venous leg ulcers in high rate, and in average you will see the mixed leg ulcers, and less you will see the arterial leg. That is the incidence rate of the three type of leg ulcers. Coming over here, what is the diagnostic measure we need to check to identify venous leg ulcers, arterial leg ulcers, and mixed leg ulcers, which is Doppler. In common way, you say Doppler. In depth, it is called as ABPI, ankle brachial pressure index. Okay. So if ABPI, which is less than 6.6, is arterial leg ulcer, and more than 0.8 is venous leg ulcer, between 0.6 and 0.8 is considered as a mixed leg ulcer. Okay. So this is the ABPI value. Now you need to understand how ABPI value is calculated. So ankle brachial pressure index. Okay. So ankle, we are collecting the blood pressure, and in brachial hand, brachial artery, you are collecting the blood pressure. Both blood pressures will be calculated using the formula what has been shown over there, and the difference value what we are getting will be analyzed as a ABPI value, which will be done in the Doppler study. Okay. So once again, I am concluding. Less than 6 is arterial leg ulcer. 0.6 is arterial leg ulcer. Between 0.6 and 0.8 is mixed leg ulcer. More than 0.8 is venous leg ulcer. This is the ABPI value. Yeah. So now management of venous leg ulcers and arterial leg ulcers. You may heard this from vascular surgeons. Compression is the therapy what they will do for the venous. Okay. So compression bandage is very much required, which will hold on and continuously put pressure on the diseased veins and slow down the retention of the blood back in the valves and push the blood back to the heart. So compression therapy is very much important for the venous leg ulcers. Coming to the arterial leg ulcers, it is contraindicated. Why? Already blockage is there, and blockage related treatments we are giving for the patient in arterial leg ulcer. And again, if you are putting compression on the artery, further it will cause damage only. So compression is contraindicated on the arterial leg ulcer. Compression is indicated in the venous leg ulcer. That is a very much important point you need to remember in the standard of care. Okay. So now imagine in arterial leg ulcer, without opening the close the artery. You're providing whatever the dressing or whatever the treatment you have, best treatment in the world, will the wound will heal? No. So understanding the internal cause of the wound is very much important. That is what in starting when Emilio is explaining, don't see hole in the patient, which is considered as a wound, see whole of the patient, which you need to look for the other parameters inside the patient body to understand why wound is stalled and how to treat this. Next, giving to Eula for the diabetic foot ulcer. Yeah.
So diabetic foot ulcers. So you all know that WHO says 85% of the diabetic foot ulcers related amputations can be prevented. So 85% is just really too much, right? So in our hands, we have an opportunity of, we in the sense like everyone in the society has an opportunity of reducing the risk of amputation for 85%. Just imagine, like out of 100, like 85 amputations can be prevented only when there is right education and awareness. So sometimes we provide a lot of education, but then if they fail to understand and be so receptive about it, yes, it's not going to work. So that's what WHO says, and always this data is something very sad to hear about, and we all think that yes, 85% can be prevented. Yes, it is very much doable, but it is sometimes sad also that we are not doing it, and patients are also not really being so aware of it. That's why like these amputations are really happening. Okay, every 18 seconds a lower limb is amputated due to complication of diabetes. Just 18 seconds, if we snap now, 18 seconds one limb is amputated due to the complication of diabetic foot ulcer. I mean diabetes. Okay, diabetic foot ulcer. So diabetes prevalence and related complications. Just for you to understand the impact of the disease, I have put this slide. So totally we have 1.4 billion population in India. So out of them, 78 million have diabetes prevalence. So diabetes prevalence, 78 million. At risk of diabetic foot ulcer. So they haven't developed, but at risk of diabetic foot ulcer, 18.24 million. So it means what? 1 out of 4. Okay, 1 out of 4 diabetes is prone to develop diabetic foot ulcer. Are you all here, guys? Yes, 1 out of 4 diabetic patient is prone to develop a diabetic foot ulcer. Estimated to be suffering from DFU. So these much definitely should be suffering from DFU, they say. That is 8.8 million. Reported prevalence of diabetic foot ulcer in India, 45% of the districts don't report non-communicable diseases. You understand? 45% of the districts in India don't report non-communicable diseases at all properly. With that itself, the diabetic foot ulcer prevalence, reported prevalence is how much? 2.19 million. What if all the 45 districts are also reporting? Then it will be even more, right? So always the diabetes related data is very, very alarming, scary, and it is very sad to know. Prevalence of diabetes related leg amputations, 0.1 million. Okay, 0.1 million. Then discussing about the snacks. Okay, so this is the status of diabetes prevalence and related complications in India. And we all know, we have been talking about infection a lot, so I don't want to go into it. And you all know now that chronic wounds are very, very prone for infection compared to the acute wounds. And more than infection, many times it's very important that we go a little further and understand the biofilm formation and how to really remove the biofilm from there. So in DFUs, it's very important that you follow VIPs. Okay, vascular and infection or biofilm or inflammation. So vascular, yes, ischemia, ischemia, non-ischemia, infection or inflammation. P stands for pressure and sensation. So pressure mapping so that it helps in ensuring what? Good offloading for the patient. So how compression is a golden standard for venous leg ulcer. Likewise, offloading is the golden standard for diabetic foot ulcer, no doubt about it. In any study that we have done, morning what I have been talking about, which is Explorer study, if you take also, 99% of 240 patients have been clearly what to say, checked for offloading compatibility. Okay, so offloading is very, very important. It's a golden standard in diabetic foot ulcer management. The same thing for compression, which is a golden standard for venous leg ulcer management. S stands for sensation. So neuropathy assessment, monofilament and tuning fork. Yes. So always when you treat DFUs, make sure you're following VIPs, VIPS. Okay. And neuropathic diabetic foot ulcer, which actually comprises of 35% of the diabetic foot ulcers that we treat. Yes. And neuroischemic diabetic foot ulcers, 50% of the diabetic foot ulcers are neuroischemic among the ones that we treat. And ischemic diabetic foot ulcer, 15%. You all know the meaning of all these diabetic foot ulcers? Yes. Neuropathic diabetic foot ulcer, when the peripheral neuropathy is there, like the nerves have been damaged. What are the three different nerves and what are the three different neuropathies among the peripheral neuropathy? Motor neuropathy, sensory neuropathy, and autonomous neuropathy. So autonomous neuropathy, which mostly you see dry, flaky skin for the diabetic foot ulcer patient. Sensory neuropathy, loss of protective sensation, very common, right? After there is bleeding only, they'll come to know my foot has ruptured because there is loss of sensory perception. And motor neuropathy, foot deformity. Give an example. Okay, we will see about it. No problem. Okay. So neuropathic diabetic foot ulcer, when the nerves are damaged in all three ways, motor, sensory, and autonomous. Sometimes like the percentage distribution of all these will be different as well. One of these three will be more, or two of these three will be more. Yes. And neuroischemic diabetic foot ulcer, both nerves and vascular function will be out, affected. Okay, ischemic diabetic foot ulcer, nerves is okay. There is ischemia. Most of the time, arterial leg ulcer will look like ischemic diabetic foot ulcer, or ischemic diabetic foot ulcers will have the same characteristics of arterial leg ulcer. Okay, please don't murmur. It's very difficult for me to listen to it. Okay, and assessment of neuropathy. You all know this 10-gram monofilament assessment, right? Simmons-Weinstein monofilament test, we call it. So place the monofilament on each area of the foot perpendicularly until the monofilament buckles and they feel the pricking sensation as well. So this is one of the tests. I'm just going little, all these are practical things that we do. So I'm just going little fast on this. If vibration is sensed, they do it with the tuning fork. So assessment of neuropathy, again, they do it with the tuning fork. So vibration, first they'll start with the first picture area where they have put A, 1A. So there they will start and there is no sensation. Again, they'll move on to the B. If there is no sensation, C, B. So until where or from where the neuropathy is or until where there is good nerve function for the patient, that will be tested with this tuning fork. So they'll vibrate and then they'll put the backside of the tuning fork on the tissue. So this is very important. The tuning fork and monofilament have been tested for the neuropathy assessment. Okay, what is offloading? What do you do with offloading? Simply reducing the pressure in one particular area where already patient is prone to develop an ulcer. So they already have this problem of really having a bad gait in the sense walk. They have a bad walk sometimes because of motor neuropathy and some bone deformities and everything. And along with that, imagine the patient is also having loss of sensation. What happens? They don't know where they are putting pressure because there is no pain. There is no pain for the patient. So they don't know where they are putting pressure. So automatically what happens? The pressure is not distributed properly. In order to relieve pressure from one particular area so that we prevent a break of skin and we prevent an ulcer forming for the patient, what do? We redistribute the pressure by providing an offloading device. You all get it? Yes. So always the total contact cast is considered to be the gold standard of DFU offloading. But then now a lot of advancements have come in offloading. So offloading shoes and whatnot for a lot of walking patients, for athletes, also a lot of offloading footwears have come. So offloading is considered to be very, very important when it comes to DFU management. So foot plantar pressure measurement. So this is one of the tests that we need to do to understand the or understand or decide the offloading for the particular patient? Yes or no? So pressure redistribution platforms will be kept where patient will be allowed to keep the foot on or walk on, and then we see like in the it is more like the impression and the figure that is configured in the computer screen. Okay, like we'll see like wherever there is too much of pressure, this color will appear, the color that is given in the foot picture here, this color will appear. And when there is low pressure, this light blue and blue colors will appear. So accordingly, whenever we see this red color, yellow color, we decide like there is too much of pressure. Accordingly, those areas have to be monitored for the patient and offloading has to be provided. So we don't want the patient to develop ulcer on those areas because already they are vulnerable to develop pressure and ulcer there. So imaging technologies and this pressure redistribution platform, what they work on is a very traditional one from a very long time. We have this, you would have seen in a lot of DFU clinics. And imaging technologies with sophisticated image processing software, something like the X-ray, they'll make them walk and then it will be captured on the computer screen and they'll be able to find out with that. And in shoe systems. So inside the shoe, a small device will be connected and we'll ask the patient to wear the shoe and walk. So when they are walking, how their gait is, where they're applying more pressure, all those will be recorded in the device. After we allow the patient to walk for some time, we will make the patient remove the shoe, take out the device, and we'll be able to find out where the patient exerted too much of pressure. You understand? So this kind of advancements like in shoe systems also we have. So with all these, the offloading slippers or the shoes, the offloading footwear will be decided for the patient. So that is very important. See, with all these measures, I think you'll all be very clear that offloading is very, very important for the patient. That's why like it is the gold standard treatment. One of the, we have like 5 to 6 components in standard of care for diabetic foot ulcer, among which this offloading is something mandatory. Other things, yes, we can take time, but offloading is mandatory. Okay, along with offloading, so this is the standard of care I have been talking about. Along with offloading, you have ischemia control, you have infection control, you have debridement, and you have local treatment. When there is infection, yes, you need antimicrobial treatment. And when there is no infection, we are very sure that the MMPs are high. So we need to go for a dressing which reduces the MMPs. Yes. Okay. So what ulcer this could be? What kind of diabetic foot ulcer this could be? Do not tell me it is diabetic foot ulcer. What kind of diabetic foot ulcer this could be? Very good. Maybe since you see, but all the parameters you can see like sensory, motor, autonomic, nothing you can say, but it is neuropathic. It's a neuropathic diabetic. Okay. Very good. And then yes, what is this? What kind of diabetic foot ulcer is this? Neuroischemic. Okay. So neuroischemic. You have neuro problem. Can you see little of dryness, paleness, and all that, and shiny skin, and the feet are looking very pale. Toes are about to develop something. Yes. So these are neuroischemic diabetic foot ulcer. These are beautiful. So ischemic diabetic foot ulcer. Clearly ischemic diabetic foot ulcer. Okay. So this is how you will identify. These are some of the example pictures I have given here. What is this one? Of course, what deformity is that? You have motor, you have sensory, you have everything here. Autonomous. I'll only tell everything is here. So what is this? How does the foot look like? What is this foot called as? I know whatever you say is there. Foot is flat, but where you can say not the foot is very flat, but then somehow the arch is missing. Arch is missing. So when the arch is missing, when it is like so much distorted, like one distorted potato, what do you call this foot to be? Potato foot? So seriously, somebody said potato foot. Yeah. Okay, what is this? Beautiful. Give it to me. Okay. So neuro-osteoarthropathy, which is actually called as Charcot's foot. Neuro-osteoarthropathy. In that only you have all the answers, right? Neuro-osteoarthropathy. Nerve problem. Yes, because of that only everything started. Because of motor neuropathy, autonomous neuropathy, sensory neuropathy. With all these, finally joints have been affected, bones have been affected. They actually break by themselves and then reassemble in a very distorted way. Okay, so this problem, and the arch is missing. She also said that the arch is missing. So this is a very, very um, not very common. But then when it comes to Charcot foot, more than 95% of the time, Charcot's foot is there with diabetic patients only. Without diabetes also, some patients, like very few, that I'm saying, like less than 5% of the patients without diabetes also are developing Charcot's foot when the bones are very weak. When the bones are very weak, or they have any osteoporosis problems or something like that. But Charcot's foot is very, very common with diabetic foot ulcer. Yes. So because of sensory and motor neuropathy, all this is happening. The hallmark deformity that is associated with this condition is the rock bottom foot, what she said. The arch is totally missing. Okay. You want me to cover this quickly? I mean, pressure injury. Moving on to pressure injuries, which is the last topic of this module, of this day. Okay.
So as we are touching on ongoing, so when mechanical load is acting on the tissue tolerance, damage of the tissue. Yeah, when mechanical load has been dropped down more, the tissue tolerance will act till one extent only, which is 70 mm. So capillary can withstand 70 mm Hg only. After that, it will constrict, or ischemia will happen for the pressure applied area. Okay. So in bedridden patients, most probably the mechanical load has been continuously put on the tissues, where the tolerance level of tissues will be crossed, and which will lead to the ischemia followed by the pressure ulcers. Okay. So here you can see the blood pressure at the arterial end of the capillaries is approximately 32 mm Hg, while at the venous end this drops to 10 mm Hg. The average mean capillary pressure equals to 17 mm Hg, and any external pressure exceeding this will cause capillary obstruction. When capillary obstructs, blood supply will be not gone to the pressure applied areas, and it develops the pressure injury. This point you need to remember. And coming over here, here what mechanical load and the tissue tolerance were acting in the pressure injury, and which is leading to the pressure ulcers. And next is shear, where it starts with friction and put with the pressure, where bony prominence will act on the opposite direction towards the muscular layer, and which was causing damage to the muscles, which is called as a shear force. Next, as I discussed it before, so we need to remember 4 terms in pressure injury, which is hyperemia, followed by ischemia, followed by necrosis, and followed by ulcer. So coming to the duration, if continuously pressure applied in particular area, within 30 minutes you can see the hyperemia. And if the pressure exerted on that same area for more than 2 to 6 hours, it is ischemia. And above 6 hours, it will lead to the necrosis, and within 2 weeks, it will open up as a ulcer. Okay, so this is the time duration for this. And understanding the root cause is very much important in pressure ulcers. What is root cause? What is the root cause analysis? Yeah, various factors involved and causing the pressure ulcer is what root cause. So until you reach the root cause why pressure injury has been happened, you're not able to treat the pressure ulcers. Okay. And we have physical causes, human causes, and organizational causes, so which will come under types of causes. Next, coming to the stages of pressure injury. How many of you had pressure injury? How many of you had pressure injury until now? Everyone would, yeah, right on. Everybody has undergone pressure injury at one point in your life. Yeah, when you slept nicely for 6 hours on your bed, you will see some Google Maps on your face, right? That is stage one. Redness, erythema, all these things. When you wear a new chappal, you will end up with the blister due to the continuous pressure applied on the particular area, which is stage two. So everyone will develop pressure injuries, but if you left untreated, it will go severe. Okay. So coming over here, as I quoted stage one and stage two already. So where you will see erythema, you can tell it as a stage one pressure injury. Coming to the non-blanchable erythema, and next is stage two, when you have a partial skin loss or blister development due to the pressure, then it will come under the stage two pressure injury. Coming to the stage three, full thickness skin loss, means you may lose dermis and epidermis. And fourth stage is full thickness skin loss with tissue also. So not only skin, underlying tissue also will get damaged. Then it is stage four. And coming to the unstageable pressure injury or deep tissue pressure injury. Here, unstageable pressure injury, I have sure. Okay. So here, in unstageable pressure injury, scar will be developed, right? Scar will be developed on this pressure ulcer, where you cannot able to identify what is the depth of the pressure injury or what is the stage of the pressure injury which is inside the scar. Next is deep tissue pressure injury. Most probably happens here for where underlying tissue got damaged, and then you can see deposits of discoloration of the skin on the top layer, and until you remove that skin and observe what was happening inside, you cannot identify what stage and what is the extent of the pressure ulcer which has been inside, which has been developed inside. Will come under the deep tissue pressure injuries. A beautiful example quoted here. Stage one, discoloration you can see in the apple. Stage two, loss of epidermal layer. And stage three, where you lost full thickness of the skin, dermis and hypodermis. Yeah. And stage four, with muscle pressure injury. And the undermining, tunneling, all these things come in this stage only, stage four only. Next is suspected deep tissue injury is which was happening due to the shear force. Unstageable is which was happening with the scar development. Okay. So I hope we covered all the stages.
Sometimes the deep tissue injury you confuse with other things.
Stage one.
Very good.
Yeah. Moreover, healing pattern also. Stage one with standard with proper protocols, we can heal it in less than 3 to 4 days. But coming to the unstageable, suspected deep tissue injury, it won't heal that much easily. Yeah. Not beautiful pictures. Pictures of pressure injury showing stages. Stage one, you can see the erythema. And stage two, where you lost partial layer of the skin. And stage three, subcutaneous loss. Yeah. And stage four, when end up with the muscle or bony prominence. And deep tissue pressure injury.
This is the difference. Very difficult to find.
Stage one. Stage two. Yeah, unstageable pressure injury with the HESCA. So now tell me, what is the golden standard? As we have discussed, venous leg ulcer compression is the golden standard. Diabetic foot ulcer offloading is the golden standard. Very good answer. Positioning is the too many chocolates for this man. Positioning is the golden standard for the pressure injuries. Yeah, what is this? Mucous membrane pressure injury. So where patients has been connected with the ventilator support, so the instruments which has been putting pressure on the mucus layer inside the mouth and putting pressure on the layers of the skin which is inside the mouth and developing this pressure ulcers, which is called as a so mucous membrane pressure injury and device related pressure injuries due to the urinary catheters, masks, IV cannula. Yeah. So all these things leads to the device related pressure injuries. And as ma'am said, positioning is the golden standard. And we cannot able to say this position is providing relieving patient from the complete pressure. Compared to the other positioning, this is better one, which has been approved by NPIAP. Okay. So my video is not playing here. So patient will be not turned completely to the lateral side. So with the support of the pillows, patient will be turned 30 degrees towards the lateral side. 30 degrees. Okay. So you can. Sorry, my video is not playing, but if you search in YouTube, yeah, let me give another option. If you search in YouTube with rule of 30 degrees, you will get lot many videos. You can see over in the YouTube rule of 30 degrees. And coming over here, after giving proper positioning also during the nurse's shift change, the position has been repeatedly used. For example, if the patient has been turned before one nurse leaving the office to the lateral position, and next nurse will imagine that patient is still in the lateral position, he may turn to the some other position, uh, which has been used in previous 2 hours. So this clock-like measure will help in avoiding the repetition of the same positions during the duty shifts or change in the nurses. So what is this clock position is? So we know we have 3 positions mainly: supine, 2 lateral positions. Okay. So if you take the print of this clock and keep in your wards when pressure injury patients are there, so whoever nurse in charge will be, or whoever doctor will be, at 12 to 1, patient should be in that position. 12 to 2. Okay, so if you are maintaining this standard as a protocol inside your hospital, so at this particular time, the patient will be in this position. When it was been maintained, you can avoid repetition of the position of the patient, and position will be done without your support also. Maybe you can say to the ward boys or relatives who are beside them to keep change the position accordingly to the timing, so that position will be done properly. Okay. So as Beulah said, donut things should be not used in the pressure injury patients where it will cause furthermore pressure injury. And during my nursing period, I have seen the clothes which has been filled with the water and used to relieve the pressure. Fluid bags and hot water bags, all these things has been used to relieve the pressure of the patients, which should not be used. Fine. Coming to the management of pressure injuries, stage 1. There is no visible wound. You can see only erythema here. So less considerably, a moisturizer or some position change will also relieve this. And coming to the stage 2, consider antimicrobials in the susceptible patients and secondary absorbent dressings according to the X-ray type. So in stage 2, you may see loss of the skin till dermis, where you can see release of the X-ray, and this wound is prone to get the infection. You need to plan the management accordingly. Coming to the stage 3 and 4, it was very deep, and as you know, X-ray should be minimized, and antimicrobial treatment should be provided, and dead skin should be debrided. All these measures should be taken in the stage 3 and stage 4. Coming to the unstageable, debride if indicated. If you find debridement is required, you need to remove the eschar, or you need to remove deep tissue pressure injury also. You need to debride, and you need to check what is the development of ulcers which is progressing inside, and follow the treatment based on the previous stages what we have seen. questions and answers. If you get any questions, you can question us. And meanwhile, video is not working. Take 2 minutes and done this. One more QR code is there for feedback. Okay, quickly finish it.
This takes 5 minutes.
Use the note so that it will be really resolved. Fine, followed by feedback.
Yes, yes. Should we remove? Is it okay? Everybody has scanned it? Okay, then, okay. Okay. So you please must be tired. Have a seat, long standing. phone that you again. Everybody has done it? Okay, now it's the time to thank our coordinators, faculty, and the speakers. So I request please take your chair in case the seat is there or not. Dr. Mahapatra has come. I want this to be done by Dr. Mahapatra. So Dr. Mahapatra, please felicitate our speaker. To begin with Behula Priyadarshini. Venugopal. On behalf of Emilio, Pratik can take. Pratik, please come. You'll have to courier him or whenever he comes. Yeah. So thank you once again, all our course coordinators and the speakers. And now it is the time to congratulations all the participants who have successfully completed the course today. So clap for each other. Now these certificates will be given by Dr. Mahapatra and also our two course faculty together. And as you come, please come here, take a photo, and certificates, please, can you give me? Now there is a way I can call by name, or you come by convenience, whichever. So please. Now it is not arranged as per the. So Jasmine. Please come. No, join because. Prem Kumar. At the end of we will have a group photo also. Sathia, Karnit, Hangaraj, A. Jayanti, Sathi Lakshmi, Sathi Lakshmi S. Ajanta Rani, Dr. Praveen Pandey, Dr. Jacob, Grace Montaro, J. Deva Tarunayam, Sadiq Ali, Jai Shri S. Keep taking the photos. Otherwise these people will not have photos. Ani V. Margaret Kath, Anupriya K. Shabnam Kausar, Gokul K. Dr. Anand A. Nishani Day. Arushi Dhiman. Oinang Kagu. Anybody left who has not got it by mistake? Everybody got it? Please come. You can write the name. Oh, no, she can write herself. Photo. No, photo one by one. Anybody else who has left? We will keep 2 or 3 buffer with us in case somebody has lost. There is nothing like. Please come. What is your name? Come, please come. Anybody else? Raise your hand. There are one or two our OT staff who are participating, but we will give, so 3, 4 we will keep it as a buffer. Okay, na? So congratulations once again on you. It was a long standing session and 5 hours, 6 hours. So you have done wonderfully. Now I will request Dr. Mahapatra to give vote of thanks. Then we will have a national anthem and then group photo. So vote of thanks from Mr. Ram. Who's that? Come. You want to give vote of thanks? Then finally from our department. Yeah. Dr. Triji, Dr. Mahapatra, Dr. Dinesh.
So I think it is without you all, it is not possible. I think very, very difficult to just sit for the whole day for a day. I think you had an inclination towards learning. I think that shows about your commitment as well as to learn new things. That is about okay. So thank you all. I think
Dr. Mahapatra from the Department of Plastic Surgery. He would like to deliver.
Okay, thank you, Mr. Ramasa. Thank you. On behalf of the Department of Plastic Surgery, I would like to thank all the participants who have come here and attended for last 5 hours sincerely and finally got your certificate. And I thank the administration first for giving us this opportunity for this platform to do this activity. I am thankful to Department of Telemedicine and Professor Ravi Kumar Chitoria, who is the head of Department of Telemedicine, for telecasting it almost so many places, YouTube and all, it has been shared. So it is almost telecasted to some 35 medical colleges, not only a local program, it is telecasted everywhere. Then thanks to all the department faculty members and our colleagues of the department who helped in organizing this event. And thank you for the course instructors, Ms. Beulah and Mr. Venugopal for doing it. And I thank you all again, Urgo, for giving this support. And we look forward to more such association in future. Thank you very much.
Thank you, Dr. Mahapatra. Now I request all of you to rise for the national anthem. Thank you. Please arrange yourself in the order of height in the corridor. So some of you can just sit and then like that, so that everybody will be seen in the group photo. So please come outside in the, because in this room it will be difficult because we want everybody's. So we will stand in the corridor.